The post-lunch session, we will be talking about session on emerging trends in onco imaging. We would love to invite our chairpersons, Dr. Aishwarya, who is Senior Consultant Radiologist in Cambridge University Hospital. Her area of specialization or gynec and onco imaging. And Dr. Mayvale, Senior Consultant, Nuclear Medicine, PSG Hospitals, Coimbatore. And our first talk is by Dr. Bhagyam Raghavan. She will be speaking on recent advances in onco imaging. Over to you, ma'am.
Yeah, my slides have not come up on my computer. So a very good afternoon. The mostly post-lunch session and the most sleepiest session sometimes, but let's try. So what is a recent advance? Any recent advance has to last. It's recent and it should last for 20 years. So there has to be a thought process that is innovative. And what do you mean by innovation is you take a concept execute a concept which addresses a function and achieves value superior to all other concepts, not only at that time, for the next decade, more than a decade, particularly when we talk of radiology. Okay, so in this, what we have now is photon counting CT, AI and digital twinning. I know everybody has talked about AI, but the final pinnacle of this is digital twinning in terms of personalized medicine. Then you have in MR, what is really going to be a game changer is newer sequences and the portable MRI, which is going to slowly become an office practice in the next 30 years. You will not be doing general radiology with AI and this. So this is my thought. Let's see what happens. Anyway, I won't be around to really see what's happening. Now I took a large topic. I'm going to stop whenever I finish. Head in my time frame. Aishwarya, give me 5 minutes. Dr. Aishwarya, give me 5 minutes. So what is photon counting CT? It uses a new energy resolving X-ray detector to count the number of incoming photons and quantify photon energy. This technology results in higher contrast to noise ratio, improves spatial resolution, and optimizes spectral imaging compared to conventional energy integrating technique. Now, when you look at traditional energy integrating system, all of us know that the X-ray photon hits a scintillator first, and which is a gadolinium sulfide, and then it turns into visible light, which you're able to see here. And with the AID detector, the photons hit the detector at the same time. They're all added and integrated to create signals that are used to create an image. And the process produces, it's a light, and it is not giving you any energy level for individual photon. And not only that, because there is cross absorption, so there is a tiling and a separator. All scintillators need to be tiled using individual light blocking septa. You see it even in the large direct detectors, the large detectors which you see, you do see the tiling, and the space occupied by the septa, no light can pass, so it results in a dead area. Whereas photon counting CT, what happens is the detectors convert X-ray photons directly into electrical signals. They are electron pairs, and what happens is it is directly proportional. The charge cloud that is generated is directly proportional to the X-ray photons, and you have an enhanced spectral information. And so you can see the electron pairs, and then what happens is you put in a bias voltage, and the electrical field causes a fast drift of charges towards the anode pixels, and the electron induces a short charge pulses when approaching the pixelated anode patch. Now, what happens? Now, there's so much of data, so much of so much of energy converting the X-ray photons converted into actual energy, actual bias voltage. So what you do an energy binning. So you separate them into the photons that fall within a certain range. By separating the photons into small number of bins between selected X-ray ranges, we maintain knowledge of the photons and are also able to manage the data of the system that generates. Now, we use the semiconductor, which is a gadolinium telluride. This was the first one used by Siemens, and it converts them again, just as I showed you in the other image. In each pixel, each detector is converting them into electrons. But then this as a semiconductor, silicon is far superior. It's cheaper. It has a lower atomic number, but then it is too thin. So what happens is it is too thin, and because the atomic number, because of the way it has a low atomic number, so when you keep it flat like this, it does not collect sufficient number of electrons. So the G has patented this a technique by which it is kept on a vertical way, the edge-on way, so you can, the effective depth of the detector is determined not by the thickness of the silicon, by its length. So that is why this is called a deep silicon technology. When you look at the comparison, they found that cadmium-based is less complex, this is more complex, and then this is edge-on. Then the effect is Compton effect, and K fluorescence emission is lower. Lowest energy bin is 20 to 25, whereas here 5 to 10 kV is captured. All the spatial resolution is lower, but energy resolving capabilities is higher. So these are the basic differences. Probably the kind of detector will change with various. I think ultimately in a futuristic way, I think we will have 2 or 3 detectors and you can shift it, is what I think might happen. Now you look at it, a good summary, there are no scintillating, there is no separating pads here, and this is the thresholding and counting, it's a counting ASIC, which is energy integrating application, which is not unlike the energy integrating application. So what you see here is, here we have kept the entire detecting system in a vertical fashion as opposed to the horizontal fashion, and the X-ray spectrum is also far superior. Now the advantages of photon counting CT is, so there is no reflector between the detector or a separator between the detector elements, so all the photon gets captured. Then so this improves the efficiency and the spatial resolution, greater house field unit stability and reproducibility, smaller detector elements, so you get improved resolution with constant radiation dose, reduced radiation dose and noise with maintained resolution. So earlier, if you had too much of noise, then your resolution will decrease. And so you try to avoid the noise, but then in conventional CT, by increasing your kV, your dose get increased. But here it is not so. So to sum up, the advantages of PCT is lower noise. So what happens when there is less noise? It is relevant in low flux imaging, which is seen in infants, children, and obese patients. So this is one big advantage. PCCT has a higher resolution because there are no septum, and also the pixel is much smaller, so it is easier to count a smaller number of photons per element. Then having access to the energy of the detected photons, you can apply different weights or binning, as you say, so you are able to process it much better, and you can improve contrast by as much as 40%. And dose efficiency, in the conventional CT also you have grids, and here 100% of the detector face is used for detection, and so you're able to detect the photon much better. Dose savings over 50% is compared to the conventional CT, particularly in chest and abdominal imaging. Pelvic imaging, the reduction of radiation dose up to 50%, especially when combined with aggressive denoising. Now here, I don't know whether this slide is very clear. Here you see the red one is actually your conventional CT, and here you see that the resolution in the lower kV, the detector is less responsive, whereas this follows a straight curve. So the responsivity of the of the detector is much superior for a varying kV range. Then, so you have so this is also, as I told you, in obese patients, it's very useful. It is very useful in cardiac imaging because the blooming artifact, because of, I have to talk about the case shell, which is the blooming artifact, and also the blooming artifact from calcium is avoided. Removal, virtual removal, like a dual CT also removes, but the technique of removal is much more different, and there is myocardial characterization via extracellular volume mapping. So PCCT can have. Besides that, tiny renal stones are seen much better. So now let's talk about the causal variation or the material discrimination. The energy information from the detector is used not only to find the density of the protons, but also the material composition with the body. So every acquisition is separated into data sets according to the photon energy level, and this is counted and segregated in predefined energy bins. These separate data sets can be used to generate energy weighted and post-processed image similar to dual CT images. You know, in dual CT, you have the iodine or even the calcium and you vary it. So you have separate material maps and they show concentration of the target materials rather than photon attenuation. So it can give you, and you are easily able to minus the basic, provide contrast material, contrast images of contrast media only. You can differentiate contrast media from calcium because of the material within the tissue, quantitate the type of calcium deposits, and also a host of other spectral applications. Now, energy bin, as I told you, baseline image here, it's a little dark, I'm sorry about it. Anything which is in the baseline, above the baseline, so the lower energy bins, the lower energies are completely eliminated, and then you have the various energy bins which are processed differently. And this is according to the K-edge imaging, so you of that particular tissue. So here you can see in a kind of a phantom where you have gadolinium, a liquid matter with iodine and gadolinium, and in the two-dimensional decomposition you see the water map and the iodine map. But in the 3-dimension, which is used in PCT, you are able to distinguish the iodine map and the gadolinium map. So you have different kind of energy bins, so you're able to distinguish it. The process is really very subtle and you can really see it. Now, what is the disadvantage of PCT is crosstalk. The first phenomenon is crosstalk, in which incident photons are incorrectly recorded by the detector elements. Now, photons distribute the energy as a charge cloud. So a photon that is absorbed near the border of 2 or more pixel can distribute its charges over multiple pixels. So a single photon interaction taking place at one location is recorded at multiple locations. Similarly, secondary interaction can also cause crosstalk in this type of interaction. A signal from one detector element, see, there is no separation here, and that can still contaminate, though the contamination is much less. So secondary interaction are falsely detected as external interactions. Then the second phenomenon that is there is the pileup, which occurs when the photon flux exceeds the speed at which the detector can count. So here you see three areas. So the detector cannot count, so it registers them as a single energy bin. Okay, so if 2 pulses are recorded in a similar time frame, they are either recorded as single pulse with energy equal to the sum of the original pulses, or overlapping pulses with incorrect energy level. So this is something that is existent in the PCT despite its obvious advantages. So the final dilemma, as in radiology, more like KV and MA, we always know there's a problem. Like more detector size, less K escape and charge sharing, so improved spectral separation. But the spatial resolution and pulse pileup increases. So we have to find a way to construct the detector elements. Clinical applications, because of spatial resolution, you can use it for breast CT, temporal bone, chest CT to see the nodules, cardiovascular CT, head and neck CT, orthopedic and trauma CT. Reduction in artifacts occurs with beam hardening artifacts and metal artifacts. Contrast agents, reduction of the iodine load, other contrast agents, molecular imaging, simultaneous multi-contrast imaging, virtual non-contrast imaging can occur. So you don't need, it's something like a mask where you're just able to take out without the contrast, because the energy bin is going to vary. So you also get quantification of the and imaging and material density maps like the iodine, calcium, uric acid, and xenon map. Now let's look at some clinical example. This is a conventional temporal bone, and here you can see the details of the internal ear very, very clearly. Now this is a regular EID, and here you can hear in another patient, you can see the fracture, how well it is seen. Same thing in a young 27-year-old woman, you can see the details of the ankle joint very well. So you can see how the resolution has really improved. Now here's a patient where you can see the calcifications in this. Now after eliminating calcifications, you can see the lesion without the calcification, but however the contrast is not getting eliminated. So that is an important thing. This is another one where in spectral CT, PCT, you're able to see the small dot of calcification, whereas in an EID it is not. So what is the role of this? See, we know that in renal stones, in calcifications, preventive oncology is coming in a big way. So we are able to detect small calcifications with larger areas and smaller areas we're able to predict. This one is tissue. Here you have lipid. You also have soft tissue density. Various plaques material are clearly identified using color-coded different energy bins. So if that's clear to you. Now this is an adenoma which is seen in a routine CT scan. In a PCT, in contrast scan, both are contrast. Here you can see the adenoma. Here you again see the adenoma much better with fat map. And when you see the fat map, the HU was 9.6. Now, in this image, what has happened is the fat fraction measured to 22.8. So, in one sitting, we know that we have incidentalomas. Now, what happens when we see them? So, we want to know. So, in one sitting, you are able to separate and fat adenoma and say, maybe, hey, this might not be significant. Now, so when you want to assess any recent advance, we have to see the risk profile of concept product, radiation, reliability, where resolution is very important, manufacturability. So they have looked at cost and manufacturability. Are we able to get the raw materials? Are we able to be cost effective? Does it cause an environmental destruction? One thing everybody talks about energy saving in Tesla, but what is going to happen to the big batteries which are going to be left? So they will again cause you more problems, okay? And we do not have that kind of battery charging. Ease of operation will occur in big buildings and large metros in a Tesla. I'm using Tesla. I hope Musk doesn't come against me. But you have to remember that the ease of operation is very important, and it should be familiar. We should be familiar with the process. You cannot have, it's like going from Apple to an Android. So we should actually have a system where we are familiar with the keyboard and keyboard, the way we do the CT, the analogies which occur. At the same time, it should be adaptable. So this is something what we call, when we assess a product, this is what we have to see. How much time do I have? 40 minutes? Less than a minute. So I just want to just start with a digital twin, which is actually, we use it. And in digital twinning, first was seen in Rolls-Royce. Also, you use it in urban planning in Singapore. And any type of thing, you need to have a model where there are many interacting components like the heart. A heart is a biological system, a car engine is a mechanical system. You can even use a hospital workflow, which is an organizational system. And systems have inputs, outputs, and internal states, which are often hidden. So everybody, I wanted to show you all this, that the heart pumpability, an engineer translates into a equation. He looks at it like a circuit. And this is what most engineers do when they construct. And then this is how the reality, which is the dots and the fitting, has to occur. And we use radiomics, multiple data. So we can use a lot of variables, radiomics, biochemistry, and genomics, and we integrate this so that in oncology, you can build a tumor using radiomics, clinical data, genetics, and family history, forecast tumor growth or shrinkage under different therapies. So we have really made a difference. And when you construct a model, I've just got 5 minutes, I need to talk about this. You have 3 kinds of models. This is an engineering concept where you have a mechanical model, which is based on a formula and a graph. So these are rule-based, low data need, high interpretability. So you can use this for tumor growth, radiation response, pharmacokinetic modeling for chemotherapy drug spread. Then you have the machine learning models, which we use in radiology, need high data sets, high adaptability, lower interpretability. So breast cancer detection from mammograms, MR-based lymphoma segmentation, HPE slide classification are things. Besides these, we have hybrid models which combine both physics with ML, and these are digital twin for oncology, where you create a digital twin, create an environment with all the genomics and all that, and see which therapy will work. Similarly, radiotherapy planning, and then multimodality. So I just wanted to just go through the last one, the last slide. We've had so many things that we feel, we've had so many papers which have come in the last few years. This is the review articles, data, which you can see how much we have done. Challenges, the system must be fully integrated. So if you want radiology data, we should follow the ORAD's Pakka nicely. And then manual segmentation cannot be done. We use gaming software for all the virtual reality and segmentations. And also the black box of the system is very important, and that leads to ethical and legal implications. It's an opaque system, and costs and difficulties of obtaining accurate labeling from external sources, privacy concerns, and data, of course, needs to be huge. This is the last one. This was a postgraduate student, a PhD student who did in IIT. He actually took the data from multiple brain tumors, okay? And what he did was, using virtual reality, he was able to the surgeon can now minus the bone and see where exactly the tumor is on the patient. Additionally, what the surgeon did was, he also gave weightage. How do you approach this tumor? Will you go through the motor cortex? Is a large vessel? So depending on that, he gave a weightage to the whole thing. And you can see he created a risk map where each critical structure is assigned a risk score and a safety margin. And using this, we can take a safe method to get to the patient. So for those who slept or not slept, what kind of model is this? Mechanical, machine learning, or hybrid? Cool. I've done my job. So thank you very much. And so when you look at a concept product evaluation, whatever you do, you can just die down for the various reasons I told in the previous slide. It is also at the same time, think innovatively, like how every day Isaac saw the apple, but one time the apple hit him and he was able to say. Similarly, Kekule's benzene ring, he kept on worrying about the benzene, but then he got the concept that it is the three snakes which are attached to each other and you get the double helix. So thank you very much for your attention.
Thank you so much, ma'am, for a brilliant talk and explaining all the complex concepts very beautifully. And can I ask one question?
Yeah.
So in 10 years down the line, do you think PCCT will be an adjunct to MRI, considering all the
I
advantages
don't
that
think it will be an adjunct. I have a feeling it might even replace MRI because of the levels of energies we are doing. Because MRI, if you look at the ultimately, is quite complex with multiple sequences. Okay, whereas in this you're able to segregate, and you might be able to do it with the touch of a button. I think it will replace just like how 2D 3D mammogram completely replace 2D. CT will replace, PCT will replace CT.
I agree with you, ma'am.
Thank you.
Thank you. Thank you so much.
Our next session is on PET MRI. I kindly invite Dr. Shanmuga Sundaram, Head of Department and Professor, Amrita Institute of Medical Sciences.
Thank you, Chairpersons, and good afternoon, everyone. At the outset, I'd like to thank the scientific committee and the organizers of SOIICON 25 for giving me an opportunity to be part of this excellent scientific program. And in the next 15 minutes to 18 minutes, we shall be discussing the various technical aspects of PET MRI, the possible and potential indications of PET MRI in general oncology, and I like to highlight some of those indications with our own clinical examples. Whenever we talk about hybrid oncology imaging and hybrid oncology equipment, I think PET MRI stands tall, and it is a true symbol of the integration of MRI with PET. It is an amalgamation of functional and molecular information with anatomical precision, exquisite anatomical details given by the MRI. So what you get out of a PET MRI is a wholesome molecular information with exquisite anatomical precision. Initially, the PET MRI concept started with sequential imaging, meaning you will acquire the MRI first, then you will acquire a PET in a nearby equipment and you will fuse it. But this is now completely replaced by an integrated whole body PET MRI from 2010. So what we have right now is an integrated whole body imaging where you acquire images simultaneously, both PET and an MRI at the same time. It has a lot of technical challenges, and this is largely taken care today by these two technologies. One is avalanche photodiode. So this avalanche photodiode works in a very strong magnetic field created by the MR equipment, and this also can be taken care by the SIPMT. This is the another opportunity and another alternate for the conventional photomultiplier tubes, the semiconductor photomultiplier tubes. But the disadvantage of this is the bore size. The size of the MRI and the integration of the PET into that has made the bore size a bit smaller when compared to a conventional PET CT, and to a very large extent the attenuation correction, which is one of the most difficult part of the integration of PET to MRI, has been taken care, and still we have some of the limitations like a truncation artifact and the limited MR field of view. So this truncation artifact is contributed by the limited MR field of view, but still the overall image quality what you get out of a PET MRI is good enough to interpret it. So this is the normal workflow. So you will always be doing a whole body imaging with the PET and MRI head to mid thigh. And whenever we talk about a whole body PET MRI, it includes the regional study also. Probably I can give an example. Whenever you do a carcinoma lung evaluation, the region of interest is of course not lung but brain. So you will be doing a regional PET imaging and a whole body PET MRI imaging. The duration is very important. So obviously patient compliance is to be noted here because it takes a minimum of 1 hour plus minus 25 minutes. Most of the time the regional plus whole body will take around 1 hour 10 minutes to 1 hour 25 minutes. So this has to be kept in our mind. And a whole body MRI sequences, normally it starts with the Dixon sequence. Dixon sequences are the backbone of the attenuation correction. Then we will have the T2 stir images, the T1 weighted images whole body, the T2 haste images, coronal images are very important for bone imaging. And of course there will be the DWI imaging, the ADC map creation, and of course the most important part, the post contrast whole body plus the regional imaging. The regional imaging depends on the area of your interest. For example, the prostate includes the multiparametric images, and whenever we look forward for a hepatic pathology, that includes the triple phase, the CT, the PET MRI also. So we normally use the head coil. Along with that, there will be normally 4 body coils. You can also use a lower limb imaging coil also. So normally this itself takes around 1 hour 10 minutes or 40 minutes minimum to a maximum of 70 minutes. So normally we use 1 head coil and 4 body coils. Simultaneously the images are acquired both for the PET and MRI. So the regular indications include the head and neck. This is the most of the time post-operative setting. The pancreas, liver, because you are looking for exquisite anatomical details. And of course in our day-to-day practice we use it mainly for the prostate, and of course for the musculoskeletal, gynecological, brain imaging, the primary imaging, and also for the lung and breast. It is to be noted in non-oncological also it is used, epilepsy evaluation, the myocardial inflammation, and diabetic foot complications. So how we have fared in the last 7 years, we are proud to have the PET MRI in our institute, and this is the 3rd system in the entire India. And as of now, we have come close to 6,000 cases till July 25, and we do around an average of around 70 cases per month. And you can note that the majority are for oncological indications, and it includes mainly the prostate. So before the prostatic, the robotic surgeries, we always routinely do the PET MRI, and because being a liver transplant center, we get a lot of cases of the hepatocellular carcinoma, cholangiocarcinomas, and of course it is always been routinely done in early cases, the suspected early cases of lung, and post-op cases of head and neck, breast, and others includes the musculoskeletal indications. Non-oncological also contributes around 22% of cases. So let us see how in the next 10 minutes, how it is relevant in our day-to-day practice. Of course, whenever we talk about staging, the PET information is complemented by the MR information with relevance to the tumor localization and the extent determination. So it is obviously contributed by the spatial resolution we get out of the MRI, the tumor invasion into adjacent organs, neurovascular structures. Classical example is the carcinoma pancreas. Also in cervix and prostate, and it is a good tool for the targeting the biopsy site. When it comes to the end staging, majority of the information is provided by the PET. So whether it is CT or MRI, because both rely on the size criteria, there is no additional diagnostic accuracy for MRI. But when it comes to M staging, especially in liver, brain, and skeletal metastasis, the detection rate is more accurate when you do PET MRI when compared to a PET CT. And of course, the marrow involvement can be reported with confidence, especially to target the biopsy, things like multiple myeloma. So the M staging is highly contributed by the integration of the MRI and the PET. Of course, in response assessment, apart from the SUV reduction from the FDG PET, we can also depend on the DWI images because it reflects the tumor cellularity, and the restaging before the surgical resection post neoadjuvant is further contributed by excellently by PET MRI. So especially in cases of carcinoma of pancreas where the patient is treated with neoadjuvant, now to understand whether patient is the right candidate for surgical resection, this is a good tool. So when we come to the other day-to-day practice, I thought instead of talking from the literature, we will show some classical images to drive home the point in what way the PET and MR integration is helpful. So this is a classical example where there is 1.5 millimeter prostate PSMA positive, the primary tumor detected nicely by the PET and also by the T2 hypointensity. But what just this image clearly shows that this is the imaging of choice, because apart from the regional imaging, you are doing a whole body to show that there are no pelvic or there are no distant metastasis. Also, this is a great investigation for the assessment of the neurovascular bundle, the adjacent structure. Is there any invasion into the rectum, any invasion into the urinary bladder? What is the status of the seminal vesicle, the rectoprostatic angle, and the neurovascular bundle? So this is the classical advantage of parametric imaging done from MRI, and you can integrate that PET. So the T2 hypointensity in the prostate, is it extending into the seminal vesicles or not, can be further documented by this integration of the PET MRI. And I like to highlight at this point, in no way a software fusion of a PET and an MRI can equate this integrated PET MRI imaging, although many other centers do that. And the MR false negativity like hemorrhage and also the post radiation changes are taken care by the PET. So whether there is PET positivity or not helps a lot to understand the true positivity of these lesions. So the false positivity also in the PET MRI or in the MRI like hemorrhage. So this can be clearly shown. So you can see here that the T2 hypointensity is not contributed or is not matching with the increased PSMA uptake there. Rather, this is a less uptake. So the therapy response assessment also can be done very well. So whenever we talk about head and neck cancers, the most important advantage is the exquisite anatomical details you get out of an MRI. For example, the physiological uptake of FDG in the normal sites like the uptake by the lymphatic channels and also by the lymphovascular tissues, this can give a false positivity. So here is a enhancing lesion at the dorsum of the tongue, and this, if we had seen only the PET, we could have passed it off as a normal uptake or a muscle overactivity. But when you see it along with the MRI image, so you are very clear that this is a real positive or a true positive image. So the enhanced involvement of the specific structures, for example, what is its real extent. So when we want to talk about the extent of this lesion, whether this is involving the left pharyngeal wall or the hyoepiglottic ligament, so these are the information we get out of the MRI. And I don't have any hesitation to say that whenever we report a PET MRI, it is not reported only by a nuclear medicine physician, it's always reported along with an MRI specialist, and this is the true value of a hybrid imaging and the true value of working together with the radiology and nuclear medicine. So these are some of the classical examples of using the integrated imaging. For example, as you know, FDG can be negative in well-differentiated hepatocellular carcinoma, and this is a 2 millimeter, 3 millimeter arterially enhancing lesion picked up on the MRI, and this is completely negative on an FDG. So the mere negativity of the FDG does not rule out the presence of a hepatocellular carcinoma, and this again highlights the relevance of an integrated hybrid imaging, whether it is PET CT or PET MRI. But PET MRI has an additional information because of the ability to pick up even subcentimetric lesions. So this is another relevance of using two different radiopharmaceuticals. So this is the patient with the hepatocellular carcinoma in the right lobe. Everyone will pick it up both from the MRI and also from the FDG. But what is important is the left lobe lesion, even though it is picked up on the MRI, is actually negative in FDG but positive in choline. So amino acid tracers are really relevant. Phospholipid tracers are really relevant in well differentiated malignancies of the hepatocellular. So this is another additional information we get it from cholangiocarcinomas, whether this is a mass-forming cholangiocarcinoma or an infiltrative type of cholangiocarcinomas, and additional information from MRCP. So this is the imaging of choice, and also by combining it with the whole body PET, you are able to confidently say the presence or absence of the lymph nodal and the distant metastasis. So the integration of the MRI, so we routinely do MRI, especially in the infiltrative type of malignancies of suspected cholangiocarcinomas, has a high diagnostic accuracy, and also it helps the physician or the surgeon to decide on the further therapy management. So when it comes to the breast therapy response also, so you go both by the MRI and also by the FDG. So any reduction of the SUV by more than 50%, you are sure about the therapy response, and you can also use the DWI images. And there are some the false negativities of an FDG. So those are taken care. For example, the small lesions, and here is a C3 spinal cord lesion, very intense uptake, and the anatomical details are provided by the MRI, and the functional details are provided by FDG PET. So this is again a very relevant investigation. So this is a patient presenting in a post-mastectomy neck pain, and the investigation is of great help, not only the regional imaging but the whole body imaging. And the meningeal involvement, so this is something negative with relevance to the FDG PET. FDG PET can be falsely negative, but here is a patient with a meningeal enhancement. Of course, there is a positive uptake also. So apart from the obviously known skeletal lesions, the presence of meningeal involvement. So whenever a patient suspected to have meningeal involvement, we routinely do a PET MRI in those type of patients. Again, the primary brain tumors, of course, there are a lot of good information you get out of an MRI, but when you want to rule out the presence or absence of a radiation necrosis or a residual or recurrent tumor, apart from FDG, we can also use choline. So the information that we got that there is a recurrent lesion in the post-operative site is further confirmed by the presence of a very intense choline uptake here. So whenever there is a dilemma whether the post radiotherapy there is a presence or absence of recurrence, we use this modality. Again, in multiple myeloma, it is a great investigation tool because any marrow infiltrative disease, apart from the FDG, we can also use a new tracer, gallium pentixafor, and before that, the whole body DWI imaging of the spine and the skeletal and extraskeletal involvement on the myelomatous lesions are very great in the assessment with the FDG PET MRI imaging. So this is a complementary imaging. For example, the T2 hyperintensity, whether this is corresponding to the FDG uptake or not. So here is a patient where the FDG is negative, but the stir hyperintensities clearly show that presence of myelomatous lesions. So this is how the integrated hybrid imaging is of great help for the correct diagnosis of these patients. So what we have understood in the last 15 minutes, PET MRI is an emerging powerful diagnostic modality. But I like to highlight the point that this is for specific malignancies. So I strongly believe the indications what we discuss, like postoperative head and neck cancers, early prostate cancers, and the areas where FDG PET can be negative can be the right investigation tool. So there are some negatives like less than ideal throughput due to complexity of the imaging and the patient complaints, but the highest strength of a PET MRI is the exquisite anatomical details. And I strongly believe the therapy response can be more confident assessed in a PET MRI in the right indicated cases. And the final point, from purely from a nuclear medicine point of view, there are new radiation, the radiopharmaceuticals like the 18-fluorocholine, the DOPA for the dopaminergic tumors like the adrenal tumors, the new radiopharmaceutical in our hand, the FOPI, all these things will further redefine the hybrid imaging technology, especially in the oncology imaging. I think I will take this opportunity to thank all of you for your patient hearing, and thank you very much for your patient listening.
Thank you, sir. That was more practical presentation as always, and excellent case illustrations for understanding the day-to-day applications of PET MRI. As we are catching up a schedule, we are not allowed to ask questions. So any questions may be asked during tea break.
Thank you very much. Thanks a lot.
Our next topic is 3D printing and onco imaging. I kindly invite Dr. Meenal Chaudhary, Director of Radiology at Akash Healthcare Super Specialty Hospital, onto the stage.
Good afternoon, everyone. Today I'm going to talk, at the outset, I really want to thank the organizing committee and the scientific committee to put me here and allow me to share my thoughts with all of you. So when I was doing my PG, I always used to think that, there is a dire dearth of innovation in medical industry, because anything we want to innovate has to go through a channel of research, development, testing, beta testing, phase 1, phase 2, all of that. But this radically changed when we got 3D printing in our facility and how we are making a difference in the patient's life. My PPT will not be too technical, but here I will tell you that what is the use cases we are doing and how it has really impacted both surgeons and patients in a big way. So what is 3D printing? 3D printing actually started from non-medical industries, and it came into light in late 1980s. And it is called as additive manufacturing technique. And what is additive manufacturing technique? We can see in this video, sorry. So you have any shape, it's not working. Yeah, so you have any shape, and with the help of a computer algorithm, you can give a tangible form to it. It can be as complex as a bone cellular matrix to an as easy thing as this owl, 3D printed owl, which we just tried on our in-house 3D printing machine. So in additive manufacturing technique, basically we use different kind of media like resin in this case, and we make this 3D model by adding layers from the base to the top. It is adding layers. Now this media can be anything. It can be resin, it can be bioparticles, it can be a drug delivery system, it can be alginate, it can be anything. Okay, we have various colors. I'll show you as I go to my my next slide. So what are the application of additive manufacturing as of now in healthcare? This is an ever-evolving thing, but as of now, clinical application, we print tissues and we call them patient-specific anatomic models. We print implants and we call them patient-specific implants. We make surgical tools like jigs or drilling guides or patient-specific cutting and drilling guides. We call them jigs. We make dental implants and guides and customized implants and even prosthetic limbs, like fully functional prosthetic limbs, which is made in 10 days specific to your patient requirement inside your hospital. It also has education sector applications where 3D printed libraries of disease anatomies can be put and hands-on surgical training. So for example, if we have a very complex brain tumor and the surgeon wants to simulate that very patient's surgery before going into the OT, with the materials which simulate skin, blood vessel, brain. So we use similar kind of materials to make these different tissues, and in the lab, the surgeon can practice, doing the surgery and modify his approach basis what nerves, what vessels, what tracts he is finding on the way, and the doctors are very, very confident even before they are inside the OT. What are the research applications? R&D of new medical devices. Now, bioprinting is coming in a big way. So what is bioprinting? Bioprinting is printing biological materials from the cells of the patient. For example, if a person has a meniscal tear or the meniscus is completely, eroded, completely degenerated, NASA has put up a lab in space where they are printing meniscus. And you can use that biomeniscus to implant meniscus inside the patient to give him a bioimplant. So this is called as bioprinting. Transplant of human organs. As we all know that the waiting list of transplant is too high as compared to the organs which are available. So with the help of this 3D printing, we can print organs and transplant them in human bodies. Drug delivery system. So in IIT Madras, this study is going on where we can implant drug at the local site of tumor and put that implant in the patient's body. So the innovations are endless, only we just need to know the basics of 3D printing. So 3D printing in onco imaging, it is helpful to identify complex abnormality. It is really helpful in the communication with the patients, with the surgeons. Sometimes we as radiologists think that we have, shown them a 3D digital image and now the surgeon understands. But in contrast, when we started using this physical, tangible print in their hand, we came to know that there was so much gap in what we say and what they understand. So with the help of, these tangible models, mini models, there's a clear-cut communication which goes to the patients, attendants, and the surgeons. In teaching and learning, of course, we have our 3D print library. I'll show you. Then in identifying complex heart defects and how the blood is moving through those defects. Of course, in patient surgical and radiotherapy planning. So this is a model of a patient's foot, showing skin, bones, vessels, nerves, everything, inside the hospital. Again, RCC printed at the hospital for patient education purposes. Now we can have these visual models or functional models. Functional models where a doctor is basically doing a simulation surgery inside the lab. It can be used for medical training for your junior doctors. And visual models. In visual models, we can, of course, better our communication, and by seeing it, the surgeons have a better idea what to do inside. So for example, this is a case of normal VST and we printed it. It's a 3D model of the heart. And this is how the CTVS surgeon was looking at the heart inside his OPD and was showing to the patient and was showing that where the defect is, how he will correct it and what he will put, and after that what will happen. So this is how we are using it in our facility. There's a lot of role in 3D printing in radiation oncology. For example, patient-specific boluses, which conform to the patient anatomy. For example, it can fit well on the patient's ears. There are no air gaps and there is no, scatter of the radiation. Immobilization devices fit to the patient bite, fit to the patient's neck, and they're so comfortable while getting their done. Radiation shielding. Now we can also make 3D print models of radioprotective materials, which help prevent scatter and help focus the radiation dose to the target area. Accurate dose distribution. So now, again, in improving efficiency and streamlined workflows, we can do rapid prototyping. The prototyping can be done in as less as 4 days inside the hospital. So there's no need for patient to wait or the doctors to wait. Eventually, it turns out to be reduced cost because there is so much less wastage which happens because it is very, very patient specific. And workflow optimization. It is used in, as I said, as analytical models and research tools too. And various material considerations are now ongoing where we are delivering drugs to the patient, we are making drug delivery systems, we are making radioprotective shields, we are, the possibilities are endless when we come to it. So this is a small chart where I'm going to tell you how we do it in a very nutshell, and then we'll go to the cases. So we have patient data from the imaging modality. It can be CT or MRI. And then processes of these images happens. Basically, we acquire images in DICOM format and our software converts it to an STL format, which can be read by these 3D printing softwares. So these 3D printing softwares are 3D slicers or mimics or materialize. These are the name of the software. We are using materialize and quite happy with it. Then the transformation of digital model into 3D mesh, and we can now give our cues to that mesh, that how do we want it to be printed? Do we want to put some mobility inside this implant? Do we want to put some areas where we can put in say, biostabilizer like fibula inside these implants? I'll show you the cases. And then finally the model is manufactured, and again, after teaching it to the patients, after communicating with the surgeons, we are ready to print the actual model in titanium or whatever material we want. So this was now let's come to the cases, and it will be the interesting part of the presentation. So this is a 39-year-old Uzbeki woman who had a history of severe pain in right ankle joint for 5 years. She underwent excision from there in Uzbekistan with bone grafting. No biopsy was set at that time. She was asymptomatic for 5 years and now presented with swelling and pain in right ankle. So there it was, this tumor which was there, including the talus part of calcaneum and navicular bone. And then the patient was planned for tumor excision with medial malleolus osteotomy approach. Initially, they put a cement spacer, and finally, we had put a titanium 3D implant. So this is, once we printed the implant, then the surgeon thought that he needs to have a space for biological fixation of the implant as well. So again, in that implant, there was this space was made for fibula to go inside to hold the implant in place. And hence, again, a 3D customized implant was made. So what you can see, this white color thing is the guide from where the fibula will be inserted inside the implant. And after post-op surgery, this is the X-ray. A titanium implant, well fitted, made specifically for this patient. And patient is now with 3 years follow-up with us and doing very well. This is a gunshot wound. Why I'm showing you in this an oncology conference? Because I want to show you how 3D implants can really fill the gaps, whether it is bone imaging, whether it is soft tissue imaging, whatever it is. So there is this guy, 54-year-old male. He had a gunshot, a firearm injury through left orbit to skull base. Now look at he presented to us after 5 months of injury. You can look at the gap. The one zygomatic process, maxillary process, everything is gone. Mid-facial bones all are shattered. The maxilla is not there. Upper part of denture is not there. Now this patient came to us, and we thought that he is the right candidate for 3D printing. This was the pre-operative image. You can see nose and maxilla are all flattened out. And we did a 3-stage procedure for this patient. This was a pre-operative images, and we had to mirror image the maxillary process and the zygomatic process to form the contralateral zygoma, nose, and there was, so this implant was designed with maxillary abutments, which will later on carry the denture for this patient. So this is how it was designed. And you can see second stage surgery was an intra-op image showing maxillary augmentation. Now you can see very well the maxillary part of the face is now augmented. Nose and everything is now seen, like there is a form to it. Now on the abutment, we also, in the later stage, we also implanted dentures. So this is intraoperative image of an implant fixation, and finally, after 3 months, we implanted dentures on this person, and this was the final dental rehabilitation which happened for this. So he was an army guy, and this is how he looks now. He had a very, very deformed face when he came to us, and because of the innovation of 3D printing and its magic, we are able to give him a fairly decent looking face. So my next case is a 20-year-old male who presented with pain over left scapular region for 1.5 years with painful range of motion. So this was the condition of the scapula. So we made 3D printed scapula for this patient from the contralateral side. It is called the mirror imaging in 3D print. And after the surgery, this is how the post-operative X-ray is. So the patient has full range of movement. The patient is in follow-up with us for 4 years now and is doing extremely fine. This is the operative specimen of the patient. Again, it can be used for, so this was a case where, this was a post-traumatic case where decompressive craniectomy was done with autologous bone cranioplasty. But with time, the patient again presented with bone flap resorption and regression. So with the help of, this is how the pre-op CT looked like. There was complete absence of petrous squamous part of right temporal bone. I'm afraid it's not working. 1 second, let me try. So squamous and petrous part of the right temporal bone was completely resorbed. Now this patient, we made this 3D printed implant made of titanium along with screw trajectories in place. And this is how is the intra-op images, and the patient is doing just fine. Again, my last case is a 39-year-old patient with recurrent pain and swelling left knee since past 6 months. She was a 39-year-old woman. On imaging, we found it was a GCT, and we could have offered total knee replacement or partial knee replacement to this patient, but the patient was very young, and it is always better if we are able to spare the native knee joint. So tumor removal and planning was done, and again we wanted to stabilize the implant with the help of fibula. So again we planned it on software, and this is how final look of this patient specific implant is. You can see 2 fibula which are crossing this implant inside the patient's body, and this was 8-month post-op scan. The patient is just fine, doing her routine jobs. So this patient could not move more than 4 steps and had very, very painful gait when she came to us, and now she is just fine with patient-specific implant in place. So this is the scope what we have done in last a year or so in our organization. In oncology, there's a lot of scope and it is ever evolving. There are certain limitations. It requires accurate imaging, data, and skilled segmentation with the help of a specialized software. And there is an additional cost, but in any ways, if we are comparing it with the run-of-the-mill implants, it is way cheaper than that. Now, what is the future of 3D printing? As I said, bioprinting for organ shortage, which is already A lot of countries are doing this work, including India. We are doing that R&D. Then we can do printing of multiple cell types simultaneously for complex tissue structures. So in conclusion, it rapidly creates precise patient-specific model, enhances planning, communication, and patient care, produces colorful, accurate models for various applications, and the future is expanded bioprinting and advanced medical application. These are some of the pictures of our 3D printers. We have 3 technologies available in our hospital. So this is the best one, which is digital anatomy 3D printer. It prints the organs just like they are, you know. So even if the patient is osteopenic, it will print the bone in an osteopenic manner. So even the calcium matrix, which is printed, is similar to what the patient has. So this is fused deposition modeling, one of the earlier, it gives us colorful images for anatomy. And this is a lab we have inside our hospital. With that, I thank you all for patient listening.
Thank you, ma'am, for the enlightening talk and showing us the amazing technology, the magic you have been doing with all those patients. And I'm sure all surgeons are going to love it if they have it in their setup. As again, we are going to reserve the questions for the tea break.
Thank you. Thank you so much. Thank you.
Thank you, ma'am, on the wonderful session regarding how 3D printing is truly transforming the patient's lives. I thank the chairpersons and the speakers. Our next session, I kindly invite Dr. Kannan, lead consultant pediatric imaging, and Dr. Rajesh Helavar, consultant radiologist, Manipal Hospitals, onto the stage. I also invite Dr. Sulaiman, Professor and HOD, Aishwarya Hospital, OMR, to present on the topic Imaging in Oncological Emergencies.
Good afternoon, one and all present here. I just would like to ask you, what is emergency in oncology? Can I get some answer from there? What is emergency? I have an honest answer. Whenever, it depends upon the clinician. If the clinician wants it immediately, then it is emergency. Mostly, jokes apart, because sometimes, our clinicians, some people ask even mild ascites or even 100 ml pleural efficient to be tapped immediately. That's not the real scenario. So there are certain things which is really, really emergency that I'm going to discuss now. So oncologic emergencies are acute life-threatening complications of cancer or its treatment, demanding rapid diagnosis and intervention. Timely and accurate imaging is paramount. Radiologists, we play the pivotal role in these critical situations. First, the thing is the rapid diagnosis. We have to give the diagnosis as early as possible. Then we have to should help them in interventional procedure, if they plan something else, also we should be able to help them. And if you do that on time, definitely it improves prognosis. So if we are taking classification of oncologic emergencies, it is classified under structural, hematologic, metabolic, and treatment related. So we have the same modalities for all. We have CT, MRI, ultrasound, PET CT, and interventional radiology. CT is fast and widely available, we all know, and it is excellent for bone. And acute hemorrhage and rapid evaluation of chest and abdomen can be done with that. MRI, we all know it is far, far superior in soft tissue delineation, so ideal for CNS and spinal cord. And ultrasound is real-time portable, no radiation, useful for effusions, vascular compression, and guided procedures. CT is commonly used in acute emergencies. We help them with interventional radiology also, like we do diagnostic angiography and therapeutic embolization for acute hemorrhages or drainages. So I'm just trying to categorize it by system wise. So if we are taking the CNS, the first thing what I have faced many times is spinal cord compression. Then comes the increased intracranial pressure, intracranial hemorrhage, cerebral infarction, paraneoplastic encephalitis, radiation necrosis, and post-operative complications. So spinal cord compression, we all know, it is the main reason for that. Mostly it will be metastatic lesion, and sometimes even primary spinal cord. It can be intramedullary, intradural, extramedullary, or extradural. And epidural soft tissue extension from the vertebral body, tumor cells can also cause that. So immediate attention is needed, and we should give the diagnosis as early as possible, because early detection prevents irreversible deficits. So we grade the cord compression by using the ESCC scale. So from grades 0 to 3, the severity depends. So this diagram actually depicts the low grade to high grade cord compression by using the ESCC scale. So what is the clinical significance? MRI guide emergent treatment, steroids, radiotherapy, and surgical decompression can be planned immediately accordingly. And early intervention can preserve ambulation in majority of patients. So MRI is gold standard in diagnosing spinal cord compression by tumor. We should assess the level, extent, cord changes, and the cause. Early detection and reporting directly impact patient outcomes. Then I'm going to discuss about increased intracranial pressure. It is if we are leaving it, if we are not reporting it on time, there can be possibilities of rapid neurological deterioration from the mass effect edema and herniation. The common primaries we all know, it is, if we are talking about metastasis, the common primaries are lung, breast, melanoma, kidney, and colorectal. The pathophysiology behind that is tumor mass plus vasogenic edema definitely increases the ICP, and it compresses the ventricle and basal systems. MRI is the preferred modality of choice. CT we can do only in emergency cases and unstable patients. So when we have to raise the red flag depends upon, like, if there is obliteration of basal systems, if there is midline shift more than 5 millimeter, then there is a transtentorial or tonsil herniation signs, then immediately we should raise the red flag. And prompt steroids, ICP control, and possibly if there is a need for neurosurgical decompression, that can help the patient a lot. This is one of our case actually presented with sphenoid wing meningioma. And you can see it is a post-contrast T1. There is a nice enhancement of the lesion. And if you notice that MCA segment, which is MCA, M1 and M2 segment, part of the M1 and complete M2 is completely present within the mass lesion. It is not easy to appreciate it. So actually it's a 40-year-old female patient presented to ER with CVA and left hemiparesis. That was a condition actually earlier. And in our image actually we found that there is a right sphenoid wing hyperdense extraaxial mass, extensive perilesional white matter edema with infarct and part of the right MCA territory. MRI was done and we found that, and you can see that in MRA there is M1 and M2 segments is not that clear. Then the next day, immediately the neurosurgeon operated it, and we told them that there is M1 and M2 segment is buried inside. Mass is completely encasing it. And next day they did it, and but they could able to do it only with some compromise. Without they couldn't able to get it out without the vascular compromise. Then we'll discuss about the thoracic emergencies. In thoracic emergencies, superior vena cava syndrome comes first. Then there is malignant pericardial effusion, pulmonary embolism, massive hemoptysis, and esophago-respiratory fistula, central airway obstruction, radiation pneumonitis, drug-induced pulmonary toxicity. Why superior vena cava syndrome is emergency? Because there is obstruction of SVC, which leads to impaired venous drainage from head, neck, and upper extremity. In malignancy, it can rapidly compromised airway and cerebral venous return. The common cause for that is malignant, which is mostly like most of the time lung cancer, especially in small cell CA, in lymphoma and metastatic mediastinal nodes. Our imaging goal should be identify whether there is SE obstruction is present or not, and we have to identify the cause, extent, and collateral circulation, and we should guide the clinician for urgent intervention. So, to identify the superior vena cava syndrome, CT venography is the modality of choice. It defines the site, length, and severity of the narrowing and occlusion. And also it shows the tumor invasion versus external compression. And we can map the collaterals, whether azygos and internal memory and paravertebral is involved or not. And MRI venography is actually one of the modality which we do, and that is a radiation-free alternative, excellent for soft tissue and vessel wall. Ultrasound Doppler is normally we do it on the bedside. It is even helpful for to rule out the jugular and upper limb veins. And chest X-ray screening may show widened mediastinum, right paratracheal mass. It's one of the case which we encountered. You can able to see that there is the SVC is not at all taking the contrast, and you can see multiple collaterals on the right-sided chest wall. So that's a finding what we get it in CT, contrast enhanced CT. MRI actually will do better. With that, we can able to identify thrombus versus tumor differentiation. Then we'll discuss about the malignant pericardial effusion. Why there is an emergency? Because rapid fluid accumulation in pericardial sac can lead to intrapericardial pressure, which can lead to cardiac tamponade. It can cause hypotension, shock, and death if untreated. So the common oncology causes are lung cancer, breast cancer, lymphoma, leukemia, and melanoma. Direct tumor infiltration, lymphatic obstruction, and metastatic seeing also can cause this. Our imaging goals to identify the presence, we should estimate the volume and assess the hemodynamic effect. And we should be able to identify that whether there is a cardiac tamponade or not, and we have to identify the underlying malignancy or any other pericardial mass is present or not. So the best imaging modalities are echo, that is on the first line base side, and CT chest. Even that can even detect a small effusions, pericardial thickening can able to see. We can see the calcification and adjacent tumor invasion. MRI heart is best for tissue characterization of pericardium and mass invasion. So CT malignant effusion may show high attenuation or pericardial nodularity. Tamponade signs on echo that can be seen: diastolic RV collapse, RA collapse, plethoric IVC. All this can be seen. All this we should search for primary tumor or any other metastasis in the thorax and the mediastinum. Massive hemoptysis. When we call it as massive hemoptysis, is large volume bleeding which is more than 200 to 600 ml within 24 hours, which will lead to airway obstruction and asphyxiation risk. In cancer patient, often from tumor invasion into the airways or vessels, that can also cause this. So the common oncology causes are central lung cancers, endobronchial metastasis, tumor-related necrosis, or post-radiation bronchial damage. Our imaging goal should be we should identify the bleeding source and identify the underlying tumor, vessel involvement, and treatable causes. So chest X-ray, it is very quick and may show mass consolidation atelectasis, but it is very limited. We cannot able to find out the source with that. So CT angiography is the gold standard. It is a modality of choice which detects the airway invasion. It can even detect the tumor, cavity, vascular erosion, and everything. It maps the hypertrophied bronchial, non-bronchial systemic arteries for embolization. Bronchoscopy is just complementary for localization, and they will do therapeutic intervention with that. CTA before intervention definitely helps in planning the bronchial artery embolization. We should look for contrast exavasation or pseudoaneurysm, that is the direct bleed site. And massive bleed can from lung cancer, often from systemic circulation, and that we should remember always, not from pulmonary arteries. So it's a case of massive hemoptysis present to our department. Can anyone tell me what's the finding here? I'm just rushing through because the topic given to me is very vast. But in between, I would like to show a few cases. So you can able to see there is a left lobe thyroid mass with there is a calcification which is directly invading into the trachea, and you can see some irregularity and invasion into the trachea. Because of that, patient got hemoptysis. And this is another case with massive hemoptysis which we encountered. This patient is known case of melanoma with metastasis. You can able to see the non-enhancing lesion within the airway, and that is left main bronchus as well as in the left lower lobe airways. You can able to see non-enhancing areas. Through that only patient got hemoptysis. So this is about the thoracic. Then we'll discuss about the abdominal oncologic emergencies. In that, bowel obstruction is quite common. Then there is bowel perforation, intestinal ischemia can happen, enteric fistulas can happen, GI bleeding can happen, radiation enteritis can happen, massive ascites, even sometimes it is like a patient will be very having a lot of difficulties. And neutropenic enterocolitis is also, that also can happen. So we'll discuss one by one. What is bowel obstruction and why it is emergency? Bowel obstruction leads to mechanical or functional blockage, which rapidly blocks the fluid. It causes the electrolyte imbalance, ischemia, and leads to perforation. In cancer, often due to tumor mass, peritoneal deposit, or even in post-treatment strictures. So in GI, what are the common oncologic conditions causes this? GI cancer, especially colorectal and gastric, and pelvic malignancies like ovarian, cervical, and prostate. Peritoneal carcinomatosis or post-surgical adhesions. So our imaging goal should be, we should identify the obstruction level, whether it is in small bowel or in large bowel. We should identify the cause, whether it is intrinsic tumor or extrinsic compression or adhesion, and we should detect the complication, whether there is any ischemia, perforation is present. So the best imaging modality, like the old school, normally we take plain chest X-ray, which will show the dilated bowel loops and air fluid levels. Then CT abdomen with contrast is gold standard, as you all know. It defines the site and the cause, and it shows transition point, bowel changes, and peritoneal disease. MRI just for problem solving, which especially help to identify the pelvic tumors. You are seeing any closed loop obstruction, which is directly shows that there is a high risk of strangulation. If you are seeing any enhancement loss, nematocysts, and portal venous gas, it shows there is ischemia. In large bowel obstruction, check for cecal diameter. If it is more than 9 centimeter, the perforation risk is very high. Cancer-related obstruction is often irregular narrowing with soft tissue mass at transition point. These are the points to remember. You can see that in this case, you can see in the X-ray there is a large bowel obstruction. The large bowel is grossly dilated, and it's a case of CA rectum. And if you see the cecal diameter it is quite large, and it is definitely more than 9 centimeter. So the chances of perforation is more in this case. So next we'll discuss about the perforation. Why it is an emergency? Because it involves it leads to the peritonitis, sepsis, and shock. There will be high mortality, especially in immunocompromised cancer patients. It requires urgent diagnosis to guide surgery and interventions. The common oncology causes is tumor invasion into the bowel, and post-treatment effects, ischemia, tumor-associated obstruction, and metastasis to the bowel. Our imaging goals we should confirm the presence and site of perforation. We should identify the underlying cause, and we should assess extent of peritoneal contamination. The best imaging modality, like routinely what we do is contrast enhanced CT with oral and IV contrast. If a patient is unstable, only with IV contrast at least, which is gold standard. And look for any extra luminal gas, focal bowel wall defect or discontinuity, adjacent fat stranding and fluid. Pneumoperitoneum is there or not, that we have to identify. In cancer patients, subtle perforation may be walled off by tumor or adhesion. So we should be very careful in finding. We should be able to find it with the utmost attention. It's a case of perforation. You can able to see there is a free gas across the midline, which outlines and accentuates the falciform ligament. The falciform ligament sign is seen. It's a case of a descending colon tumor, and you can even see the distended transverse colon. Neutropenic enterocolitis is a life-threatening inflammatory condition of the cecum and colon in immunocompromised patients, especially often after the post. It causes high mortality from perforation sepsis, and it can even lead to multi-organ failure. So we commonly see that in hematologic malignancies like AML and ALL, and even in solid tumors and post-intensive chemotherapy also, in some cases we see. So our staging goals in that is we should confirm the diagnosis in whether patient is, in case if especially the patient is febrile or with abdominal pain, you identify whether it is present or not, and always assess the bowel wall thickness, see the extent, and is there any complication present or not. So the best imaging modalities are CT, abdomen with IV contrast, which is gold standard. In that, what we see is circumferential bowel wall thickening, which will be more than 4 millimeter, usually cecum plus or minus in ascending colon. Pericolic fat standing, we see nematosis, we see bowel dilatation, we see it. Even like we can detect the perforation in a free air or abscess. USG is the initial bedside tool only. We cannot able to identify much with that. And CT is the preferred modality. Nematosis plus portal venous gas leads to poor prognosis. Always avoid oral contrast if in unstable patient to prevent delays. Early diagnosis, if we are diagnosing it early and we give a broad spectrum antibiotic and bowel rest, we can save the life. It's a case of neutropenic enterocolitis. You can able to see there is thickening of the transverse colon wall, as well as you can see the nematosis. In genitourinary, obstructive uropathy comes first, then the renal hemorrhage, then ureteric fistula. These are the common by descending order. So urinary tract obstruction, you all know it leads to renal damage. So we have to see, identify it as early as possible. I just need 2 more minutes. I'm going to finish it. So the imaging pearls in that is we have to identify whether is there, what is the degree of hydronephrosis. CT urography is better in case if it is not very helpful to identify the cause in the pelvis, we can go for the MRI pelvis with MRI urography. It's one of our case. In this you can see that it's a case of recurrent cervical CA. In that there is cervical CA directly embedded into the urinary bladder and to the left distal ureter. You can see upstream dilatation there. So one important thing what we should remember in systemic this thing is oncologic emergency is tumor lysis syndrome. What is tumor lysis? If tumor lysis, there's cell which leads to spontaneous or post, it happens immediately after the spontaneous or post therapy, which leads to the electrolyte imbalances, and it causes acute renal injury, arrhythmias, and leads to death. So image is adjunct in this. Direct diagnosis mainly clinical and biochemical. So we should assess the complication and rule out alternative causes for acute deterioration. This is one of our case actually presented with lung adeno-CA. The genetic analysis actually revealed exon 19 deletion in the EGFR gene. The laboratory tests, including the blood cell counts and chemistry, were within the normal ranges prior to the treatment initiation. The patient was administered EGFR TKA afatinib 40 mg per day as a first-line chemotherapy. On the 4th day, afatinib administration, the patient urine output decreased and dyspnea worsened. There ultrasound images, I couldn't show you the ultrasound images, but we were able to identify there is renal parenchymal change and other thing. And there is gross ascites, and in CT it showed pulmonary edema. So based on the clinical manifestation and laboratory findings, a diagnosis of afatinib-induced TLS was established. Musculoskeletal, most common fracture.
Professor Abubakar, I think in of time.
Yeah,
I think we should wrap
just
up
1
this
minute,
session.
I'm just finishing it. This is one of the case presented with distal shaft of the femur lesion. We asked the patient to get admitted and get operated immediately because we told them it's a ticking time bomb, but the patient refused and left. Next day, you can see the dates. 23, the patient has come. The next day, the patient got the fracture. So if you are finding it, it is definitely a medical emergency. So in summary, early detection definitely save lives. Prompt imaging can prevent complication. We should choose the right modality, and we should differentiate the causes, and we should guide in urgent interventions. Team approach matters a lot. Close coordination between radiology and oncology improves the outcomes. Thank you.
I think it's a very extensive topic to cover, so I understand. In the interest of time, we'll have questions during the tea break outside, and we'll get started with the next session.
Thank you very much.
Thank you very much.
Thank you so much, sir. I thank the chairperson for chairing the session. Thank you. Now we come to an interesting part of the conference where we have multidisciplinary team approach on neuroendocrine tumor, the key considerations in diagnosis, staging, and management. We welcome our esteemed group of panelists, Raju Sharma, Professor and Head, All India Institute of Medical Sciences, New Delhi, Dr. N. Subramaniam, Senior Consultant, Department of Radiation Therapy, KMCH, Dr. Firoz Rajan, Senior Consultant, Oncosurgery, KMCH, Dr. Ram Kumar, Medical Oncologist, KMCH. I invite our esteemed speaker, Dr. Ram Kumar, Consultant, Nuclear Medicine in KMCH. Dr. Ram Kumar will take us through a set of cases on neuroendocrine tumors. So sit back and...
Thank you, Matthew sir, thank you Venkatesh sir, and esteemed sir, and the entire team of Onco Imaging KMCH for this opportunity. And I welcome all the esteemed. Any guesses, PGs? Okay, I don't have time to guess. Okay. So the awareness ribbon for neuroendocrine tumors is known as zebra stripe ribbon, and the awareness month is November. So we have a neuroendocrine tumor awareness month in coming 3 months. So I welcome the esteemed panelists to the discussion. I hope we'll giving a lot of knowledge about neuroendocrine tumors. So this case. So this is a 64-year-old male with a symptomatic coronary artery disease. During the pre-operative evaluation, he had severe abdominal pain, and I think one part of history is missing here. His hemoglobin was persistently low during the evaluation. It was only 6.5, and so the cardiac team thought he might be having some colorectal intestinal malignancy. They didn't use the abdomen, nothing, and after discussion with the radiologist, the surgeon ordered further imaging. So Dr. Firoz, the surgical oncologist, senior most surgical oncologist in KMCH Coimbatore. Sir, what would be the investigation of choice? What would you order?
Hello, yeah.
The question here is low hemoglobin, so they are actually suspecting a mass.
Yes, I would have thought about getting a axial imaging, something which will give me information at least in 2 phases, the arterial phase and the portal venous phase.
Okay. So Dr. Raju Sharma, the radiologist here. Sir, what would you suggest? Will you go for an MRI or a CT?
No, definitely a multi-phase CT.
Okay. So the patient underwent a multi-phase CT, that is a triphasic CT. So these are the lesions. Sharma, can you please describe the lesions for us?
Yeah, so in the first image, your circle marks out a lesion in the bowel, possibly in an ileal loop. I see an enhancing focus in the ileal loop. And the second image shows what looks like a lymph nodal deposit in the mesentery. It's outside the bowel.
Yes.
Possibly a spread from the first lesion. I'd be thinking since it's enhancing, I'd be thinking on the lines of neuroendocrine tumor in the ileal loop with a mesenteric deposit. And in the liver, in the left lobe, in segments 2, 3, I see an enhancing focus, which is very small and tiny and difficult to characterize on this image so far.
So you were right, Dr. Sharma, though the radiologist report was a small bowel carcinoma tumor with a mesenteric lymph node and a suspected metastasis in liver, which could also be hemangioma. That was what our radiologist or oncoradiologist reported, and they suggested further evaluation. Coming back to Dr. Feroz, sir, if liver is taken as a metastasis, what is the approach? If liver is not taken as the metastasis, what is the approach?
If you accept the fact that this is a neuroendocrine neoplasm, definitely surgery is the most preferred method. It's as a rule of the thumb, surgery is the preferred treatment option. So it will include removal of the primary lesion as well as the regional nodes, as well as the metastatic lesion if it is in a operable location.
So, will you go for some other investigation to confirm whether this is actually liver mets or not?
Yes, I have a functional imaging option.
Yeah.
So I will definitely take it.
Okay, sir. Exactly, sir. So, the patient underwent CT and the primary lesion showed intense uptake, that is a primary, and the suspected lesion in liver, which actually did not show any uptake, ruling out hepatic metastasis in this particular case. But the thing is, in some cases, even hemangioma shows DOTA uptake due to the somatostatin receptor expression. In this scenario, Dr. Sharma, what would be a take? MRI versus DOTA?
So I would differ. I think in our institution, we would definitely do an MR with diffusion, knowing the resolution of PET is more than 1 centimeter. So a tiny lesion may be missed, and especially there is background activity in the liver. There's background activity, so you might lose a very tiny lesion. So perhaps we do a combination of both. I might land up doing an MR with diffusion and also do a DOTA PET.
Exactly, sir. We also did an MR, and I can't find the MR image. MR also ruled out metastasis, but for literature's sake and the guidelines' sake, in well-differentiated neuroendocrine tumors, which actually show DOTA uptake, MR as well as DOTA PET-CT are comparable in terms of literature as well as guidelines. But though MR scores a little bit higher in sub-centimeter size lesions, so it's up to the clinician's take. If he feels DOTA can help, he can go for a DOTA, and if he actually feels, in this case, this could be an operable liver metastatic lesion too. So the surgeon feels he'll have better information from MR, he can go for MR. So this is a paper comparing a head-to-head comparison between DOTA and MR, and the results are comparable. And the guidelines do say the same. As far as NCCN and ENETs, recent edition of guidelines are tilting towards functional imaging because till last 4 years, there was no standardization of PET-CT because certain countries do PET-CT without contrast, certain countries do PET-CT with contrast. So there was no standardization of PET-CT. So in the evidence timeline, PET-CT featured much later. But the recent NCCN ENETs, and they have started including PET-CT in the baseline itself for metastatic evaluation. So coming back to Dr. Feroz, sir, now it's not a metastasis, it is only a small bowel carcinoid with a mesenteric lymph node. What would you do, sir?
I will plan for surgery. I will get a tumor marker. In this case, chromogranin A levels.
They were elevated.
Is one of the most useful tumor markers for following up also, as well as prognosticating NENs. So after that, I'll plan for a surgical resection. Preferably, I'll do an open surgery because many of these NENs require good palpation of the rest of the bowel. So this haptic is very, very important here, especially if there is nodal disease. You might have to change your resection planes, which might not be possible with a minimally invasive technique. So for me, an open surgery with a good evaluation of the rest of the bowel is mandatory, and this will require a resection with anastomosis.
Yes, the same thing, the patient underwent a segmental jejunal resection and mesenteric lymph node excision, and the pathology turned out to be neuroendocrine tumor grade 2. And the key 67 index was less than 10%, and it was PT3, PT2, CM0, and the resection status was R0. So what next? Is any adjuvant therapy needed from surgical oncologist point of view?
No. Except for follow-up.
To Dr. Subramaniam or Director of Oncology, sir, any adjuvant therapy in this setting, sir?
Unfortunately, radiation has very little role in endocrine carcinoma. We have to accept it, that's a fact. So for this situation, I don't think you need any adjuvant. You need a very close follow-up. The follow-up guideline is there, group of patients. So it's purely grade 2 neuroendocrine tumor. And what it needs is follow-up as of now.
Okay. Sir, and a small follow-up question. Okay, why do you think radiotherapy has got limited role in neuroendocrine tumors? Is it something to do with the tumor biology?
It's actually for the slowly multiplying tumors, generally speaking.
Well-differentiated.
Well-differentiated one. For any key 6 and above 20% is a different ball game. Anything below 20%, in fact, about 10% also, you may take it going towards a poorly differentiated tumor. But in well-differentiated tumor, generally they are radio-resistant. So surgery plays a very good role if you do a very good or not resection. The cure rates are excellent, very few recurs, and there is no benefit of adding radiation in that situation. However, if the surgeon struggles to remove certain situation, there are data from esophagus or rectum, specifically digestive system neuroendocrine tumor, where they think it's locally advanced, they may not be able to remove it completely. There could be a role for radiation in that situation. Apart from that, I can't think of that too. The data is the level 3 or level 4. It's not level 1 or 2, as you suggest. So in fact, lutetium comes into play as neoadjuvant treatment nowadays. So as of now, in this situation, no role for radiation and no role for chemotherapy as well.
Last question to you, sir. In your clinical practice, based on the evidence we have, do you think an FDG PET-CT is recommended for well-differentiated neuroendocrine tumors, grade 2, key 67 less than 10%, at least at the baseline?
I started reading after this, after you send all this detail only, then only I got this paper.
You should not be revealing, sir.
So, after yesterday, I thought there is no role, but there is a specific fantastic data now in digestive neuroendocrine tumor, up to 30 or 35% or FDG avid as well. And if it is avid, that prognosis is poor. So this data is published data. So on this basis, I think we should do both.
Okay, sir. Thank you, sir. To Dr. Ramkumar, medical oncologist. So considering this as a non-functional entity, so what would be your approach of follow-up?
Yeah, if it is a non-functioning, just a routine follow-up. In the first year, we follow up the patient with multi-phase imaging every 3 to 4 months in the first year. From the second year, we can ask the patient to come annually for history and examination and general physical examination.
Okay. If it's functional?
Depending upon the security status. If it's a patient having a high chromogranin levels preoperatively, we'll follow up the patient with serum chromogranin. If it's like other functional tumors like insulinomas, gastrinomas, the tumor marker will vary.
Any cutoff, where would you think of imaging? That is 6 months down the line, 1 year down the line, 2 years down the line. Any cutoff in biochemical levels on which you think of an imaging? Both cross-sectional.
Just a little level, there's no specific cutoff, I think.
Okay. Thank you. So the guidelines are pretty clear, and that is what our panelists have also told. In this particular clinical setting, it is R0 resection, no role of RT, and it is a non-functional tumor, regular follow-up with biochemical analysis, and no role of any adjuvant treatment. And the surveillance would be for 10 years. And imaging, if and when need arises based on the biochemical parameters. So here is a second case. So it is a 45-year-old man. His presenting complaints are high-colored urine, clay-colored stools, generalized itching, so liver obstruction, some biliary obstruction is there. No fever, but chills present. Ultrasound revealed mass in pancreatic head/unsaid process. Dr. Firoz, what would be your next investigation, sir?
When you hear hoofbeats, you think of horses. You don't think about zebras.
Yeah.
Correct?
Exactly.
Yes. So my first will be a carcinoma of the head of the pancreas, most probably a adenocarcinoma.
So to enlighten our PGs and the future radiologists, what information does a surgeon need from a radiologist about a pancreatic mass?
Yes, it's a good question.
Before
Yes, so pancreatic cancers, surgery is one of the keystones in the management. So we do have a lot of neoadjuvant treatment coming in with respect to pancreatic cancers, especially in those borderline operable states. So those cases do go for neoadjuvant therapy with radiation and chemo, and then we subsequently take it. But otherwise, run of the mill, our treatment is going to be surgery. So surgery, we are going to look at the operability, which includes the extent of the disease, whether it's involving the vessels. The vascular involvement is one of the key features which we look into, metastatic status. And another thing which we look with the radiologist is the presence or absence of any vascular abnormalities, so which will guide us in the resection. So these three things are quite important. And
okay, sir. Dr. Sharma, now it's your turn to tell the residents how to describe the pancreatic mass and what all details you would give from a radiologist point of view to surgeon.
Do you want me to interpret these
Yes,
images
exactly,
first?
sir.
So this set of image, I think the sound of these hoofbeats are a little different from what horses sound like, because this lesion enhances a little more than what a PDAC does. Ductal adenocarcinomas are hypovascular tumors and enhance less than the normal pancreas. Here we have a lesion which is enhancing a little more than the, it's not like a bright NET, but I would strongly consider that possibility also, and say that this could be a PDAC, this could be a neuroendocrine tumor, perhaps include both in the differentials. The information that I would want to give to the surgeon is firstly the morphology of the lesion, where is it located, what kind of enhancement pattern, cystic or solid, any calcification, is it truly a tumor, can it be mass-forming chronic pancreatitis, what is the status of the main pancreatic duct, bile duct, and then come to the local extent in terms of the involvement of vessels, give a detailed description with the SMA, the SMV, the celiac axis, on what is the, are there, is the portal vein reconstructible above and below the lesion. But essentially, I would want to do this in an MDT kind of setting with the surgeon sitting with me. Our surgeons would always be present in the room, see it themselves with us, and then only take a decision. And then you can go into subtle findings like perineutral spread, extrahepatic disease, and everything.
Thank you, sir. Thank you for the wonderful description. Sir, what's your turn now? It's the provisional biopsy was adenocarcinoma pancreas, and the patient had symptoms of obstruction. So, what would be your approach?
this would have gone for a resection, pancreatic head resection. I'm pretty sure that it's confined to the head, and it requires the Whipple's pancreaticoduodenectomy with the reconstruction of the biliary tree and the GI and the pancreatic duct, of course.
So, contrary to the pre-op pathology, the histopathology turned out to be neuroendocrine tumor grade 2, Ki67 is 14% from head of pancreas. So, if you had known the HP before, would you have ordered any other investigation, or would have still gone with Whipple's?
Especially if the radiologist gives me a suspicion of a NET in this, I would definitely have taken it for a investigation with the functional imaging. So it would have helped me in the decisions.
The patient underwent the Whipple's, and of the nodal status out of the 11 nodes examined, 3 turned out positive, and since it is neuroendocrine tumor grade 2, Ki67 14%, higher end of grade 2. Dr. Ramkumar, medical oncologist. So, what resection status is R2. So, what would be your approach next?
So in
Would you require an additional imaging post surgery?
yes, there is a margin is positive. We'd go for DOTA PET to look for any residue over there or any other sites of disease.
Okay. So the patient underwent DOTA PET as expected. The patient had a intense DOTA avid lymph node in iotocaval and portocaval regions. So now, considering this as a residual / recurrent disease, Dr. Ramkumar, what's your take? So there is a residual disease. So next line.
So if there's a residue and if it's DOTA positive, if it is resectable, we have to resect. If it is not resectable and is stuck to some organ, then we have to go for any local therapy if possible.
Subramanian sir, any role for art here?
I will do FDG PET as well, just to make sure any FDG element is missing or anything. So that's very important because there may be some poorly differentiated component somewhere. So that gives us an opportunity to radiate. However, in this situation, take it as grade 2. Once again, the data for radiation is limited. But people have done it. So particularly pancreatic bed and lymph node radiation are done in this situation to achieve local. You don't see a complete response like situation in this situation. The other choice is PRRT.
Sir, following up with your question, this case was in 2019. NETTER-2 data came in 2023. So NETTER-1 there was no FDG, so we didn't actually do an FDG. Okay. So to Feroz sir, sir, would you mind operating again excision of these nodes? Any chance?
Not with a 10-foot pole.
Okay.
It's going to be extremely risky. Morbidity is going to be high.
Okay. I started 5 minutes late, so please take care. So this was the comparison of data between NETTER-1 and NETTER-2. The slide why I'm highlighting is at the end of NETTER-1 in 2017, PRRT or lutetium-based therapy for neuroendocrine tumors was a second line of therapy. It was still considered a second line of therapy. NETTER-2, which came in 2023, PRRT is seen as a potential first line therapy in well-differentiated grade 1 and grade 2 NETs. So that is why this case was in 2019, so we didn't go for upfront PRRT. The patient was put on octreotide. So to Dr. Ram, the patient remained stable for close to 1.5 years to 2 years, and till the second scan, the patient was remaining stable. And when we did the third DOTA PET-CT on 2010-2022, there were appearance of new liver lesions with intense DOTA uptake, and there were new lymph nodes in the portocaval iodocaval region. So what is your, what would you do next? So this is primarily your patient now. So after the first progression, what would you do?
So most of the patients who are, even after this kind of long-term octreotide injections, if they still somatostatin receptor positive, we can ask the patient to go for PRRT therapy. If they are PRRT negative and FDG positive, we may recommend systemic therapies.
Okay. One more question to you. So going back to 2019 with the patient at the first scan, okay, the patient still had somatostatin, SSTR positive, DOTA positive lymph nodes. By going by NETTER-2 data now, would you have recommended PRRT as a first line of option?
If the patient
maybe along with octreotide, not PRRT alone, along with octreotide.
If the patient is having high tumor burden, Ki-67 more than 10%, in that scenario, we can ask for PRRT in the first line. If that is not the case, we will sequence a sequential therapy with a long-term octreotide, then we'll go for a PRRT.
Excellent, excellent. Okay. So after October 2022, we introduced PRRT. The patient received 4 cycles along with the monthly octreotide therapy. So this was the pre and post PRRT images. In PRRT, what happens is the disease remains stable. Remission status is achieved in 10 to 20% depending upon the tumor biology. This is already well differentiated grade 2, Ki-67 more than 10%. We can't expect a complete remission or complete cure in this setup, but tumor will remain non-functional, the tumor will remain stable in PRRT. So this particular patient remains stable for 3 years with 4 lines of PRRT. So next in 2025, coming back to 2025, the patient remains stable from 2022 to 2025. This is a PET-CT done in 2025, DOTA PET-CT. So appearance of multiple new liver lesions. There's a left supraclavicular node with somatostatin receptor uptake. So Dr. Ramkumar, what would be your treatment now?
That's, at this point of time, I will get FDG also, sir. If FDG is positive and SSTR is negative, already patient has progressed 2 lines, we'll go for systemic therapy. So mostly, rebiopsy. As in oncology, we always do a second biopsy if there is a system, there is a progression. We'll go for systemic therapies. Options will be everolimus. If the patient is already exposed to everolimus, we'll go for cabozantinib.
Okay. So coming back to Subramanian sir, this patient has now got 2 intraspinal cord metastatic lesions, 1 and D2 and L1. So would our RT help here, sir?
Yeah, I think importance of rebiopsy should be emphasized.
Okay.
I have rebiopsy in 2022 itself.
Okay, sir.
Because any conversion of high grade is so important for management.
Okay.
And also in recent generation, there are so many molecular markers you look for further therapies.
Okay.
So if you have disease-free interval of 3 years and it's coming back, always rebiopsy in neuroendocrine tumor situation.
Okay.
So rebiopsy is important.
Okay.
Second thing is, obviously, any tumor behaving like this, high chances of high-grade conversion. So the FDG PET will give you an idea, but you still biopsy and confirm it.
This patient,
and if it is high-grade,
as actually is not coming back to us for treatment, she is not coming to our hospital anymore, so her FDG is not done. Okay. Sir, one more question. Considering the SSTR positivity or DOTA positivity, is there a scope for re-challenge PRRT along with systemic therapy of everolimus sunitinib?
So that I understand. So I think if FDG positive, there is a role for radiation of the spinal cord lesion. That is one.
Okay.
Because you take it as high-grade conversion and possibility of response, and saving the limbs from make them walking is so important here. Second thing is combination of PRT with other systemic therapy. I'm sure Ram Kumar will answer that. The data is emerging, but the evidence is not strong as of now. But I think the study is running as of now. So whether everolimus or combining with PRT going to give benefit in high-grade transformation situation.
So this patient
as of now, they go into clinical trials, but
no
we are waiting
more
for the
hospital's patient. Okay, so he received a RT for this. And patient is on everolimus, but not ready for FDG PET, not ready for re-challenge PRRT. So, as you said, sir, but the data is very clear, prognostic value of FDG PET CT. Even in the setting of grade 1 to well-differentiated neuroendocrine tumors, as you cited, we have to do an FDG PET CT in case if you are planning for PRRT or long-term octreotide therapy. And if there is considerable FDG uptake, then these patients won't do well in the long term, especially for PRRT and octreotide therapy, and they have to be introduced to systemic other forms of systemic therapy much earlier in the treatment. So what the recent advances, we have a scoring system. So this is known as NetPET scoring system. So this is the DOTA PET CT, this is the FDG PET CT, and we will be characterizing the uptake in both the scans for the lesions. If both the scans are not showing any uptake, that is known as P0. If DOTA uptake is highly positive and FDG is negative, that is P1. And if both the uptake is present but still DOTA uptake is more than FDG uptake, that is P2. Likewise, the scoring goes till P5. The point here is, in any neuroendocrine tumors, now the score is also being done for grade 3 neuroendocrine tumors, not only grade 1 and 2. If the patient is having a score of P1 and P2, will definitely do well, at least in the earlier treatment regimes with PRRT. The patient is actually showing P3 and P4, then PRRT might work maybe in combination with systemic therapy, maybe with cetabin or everolimus or sunitinib. So this is a recent prognostication score which is being done in all patients before choosing the patient for PRRT. The point here is you have to choose the right candidate for PRRT. It's not like that every patient who should uptake in neuroendocrine tumor lesions in DOTA scan is actually a right candidate of PRRT. We have to do an FDG and see whether any FDG uptake is present. Basically, FDG uptake is a marker of poor differentiation or aggressive behavior. So the moment you see FDG uptake in a patient with NET, then you either have to alert your oncologist saying that we have to start some form of therapy in conjunction with PRRT, or as a nuclear medicine physician, we have to withhold PRRT for some time before ascertaining how the tumor actually behaves. So this case was from 2019. So these are all the consensus guidelines available for the particular context. As Dr. Ram Kumar, Dr. Subramanian said, it's everolimus sunitinib and the chemotherapy, combination chemotherapy. Rechallenge PRRT is an option if the patient still exhibits SSTR positivity in the lesions. So in this particular patient, we didn't have a chance. We didn't have a chance to do FDG PET. So I'm just showing the cases are over. I'm just showing a single case where how this prognostication actually helped. This is a case of NET duodenum with multiple liver lesions. This is the DOTA PET. The DOTA is showing intense uptake. In the same patient, we did an FDG PET CT. Absolutely zero. Absolutely no uptake. So this is a P1 case. Only DOTA uptake, no FDG PET-CT uptake. So this is the pre-therapy liver metastatic picture. So this is actually an image of post-therapy lutetium scan. So we don't see any uptake in the liver. This is after 4 cycles of lutetium. So all lesions have actually disappeared for time being. Okay, we don't know when it will come depending upon the tumor behavior. But if at all, if you're choosing a candidate for PRT, this has to be the ideal picture. FDG uptake has to be 0. These are the recent guidelines which are actually placing PRRT in combination with multiple other therapies, starting with NETTER-1, going to NETTER-2. NETTER-1, it was second line of therapy and only well-differentiated grade 1 and 2. NETTER-2 also included grade 3, and in oculo-random, it was actually combination with sunitinib, and there's one more one is complete, which is also emphasizing lutetium versus everolimus. So closing remarks, the neuroendocrine tumor is one tumor where actually imaging plays a very important role. Start radiology to nuclear medicine, we have to prognosticate the tumor, we have to define tumor margins. So in respect to neuroendocrine tumors, surgical oncology offers a chance for cure through meticulous resections. Radiology aids us with accurate staging and ongoing surveillance. Pathology determines grade key 67, biology influencing every treatment choice. Medical oncology brings together the various systemic options. Radiation oncology addresses the challenging areas, and nuclear medicine merges diagnostic with theranostics. Endocrinology and gastroenterology oversee hormones, syndromes, and provide long-term care. So overall, as far as neuroendocrine tumor is concerned, it's always multidisciplinary and a teamwork. Thank you. Once again, I thank the organizers for the chance. I thank the panelists too for their wonderful insights into neuroendocrine tumor. Thank you, sir.
Thank you, sir. We would like to extend our heartfelt gratitude to our amazing panelists. You are very informative. We love the discussion, sir. And we'd also like to thank Dr. Ramkumar for walking us through an amazing set of cases. Thank you. For the next session, we have another MDT on liver tumors, a treatment conundrum, where we wonder whether to resect, ablate, or systemically treat. For this, we have an expert set of panelists, starting from Dr. Vignesh Kandakumar, Senior Consultant Medical Oncology, KMCH, Dr. Arulraj Ramakrishnan, Senior Consultant Medical Gastroenterology and Hepatology, KMCH, Dr. Anand Narayanan, Senior Consultant Therapy, KMCH, and Dr. Pari Vijayaraghavan, Senior Consultant Hepatobiliary Surgeon, KMCH. For walking through the cases, we invite Dr. Lijesh Kumar for presenting the cases.
So good morning, everyone. Welcome, dear panelists. Dr. Pari is on the way. I'm told he is still stuck in surgery. So this I was told is a radiology crowd predominantly, so we'll keep it simple in the sense that we are not going into too much of technicalities, but we do want to get the message across that HCC is not something that you just treat by size-based criteria. It means it's not simple to take the decisions. It has to be a multidisciplinary team. So dear panelists, will we start? Yes? Yes. So all the discussions that will be there will be based on the evidence-based pyramid. This is what we are. We are modern medicine. We are evidence-based medicine. It will be strictly according to that. So just a brief overview of hepatocellular carcinoma. It's the 6th most cancer worldwide, 3rd most common cause of cancer-related death. It's most common primary liver cancer, accounting for around 75 to 86%. And men are approximately affected 2 to 3 times compared to females. I think Dr. Pari is on stage, yes.
We would like to welcome Dr. Pari Vijayaraghavan, our Senior Consultant Hepatobiliary Surgeon, yes. KMCH.
So thank you for completing our panel, sir. Yes. So hepatocellular carcinoma, actually, unlike other malignancies, is not very simple to decide the treatment modality also, because unlike other malignancies, you're not just treating with the malignancy. We are also dealing with underlying chronic liver disease that complicates matters completely. Even if you treat the HCC, you are still stuck with a cirrhotic liver, and that is a big problem. So to slightly understand means many of you may have just diagnosed hepatocellular carcinoma without understanding how you decide treatment modalities. For those of you, we have just set a few case scenarios in which I hope that the message does get across. So case 1 is a 6-year-old male patient, solitary 1.6 cm, irides 5 lesion, segment 7, child A, sodium 11, bilirubin 1.3, age 2.9, AFP 20, PIVCA 2 is 25, right? The solitary lesion, segment 7. So Dr. Arul, I hope I'm pronouncing your name correctly. Yes.
Thank you.
Yes, hi sir. So for hepatocellular carcinoma, so what's the most common staging system that is used for HCC?
So predominantly, it's always been the Barcelona Liver Clinic system, which has been used.
Yes.
So it's just based on sort of simple characteristics, looking at how the liver functions and the performance status, and to the size of the tumor. Based on that, it's been split into early stage and very early stage and stage B, C, D. So the D is primarily reserved for people who've got poor performance state, irrespective of whatever the tumor comes down to. So I think that's something that which we are not going to discuss here, so we'll not. So for that sort of group of people, the parameters used is the day-to-day albumin, bilirubin, and all those things are the ones that which I as an hepatologist would be looking at. And radiologists would guide us about what's the tumor size and everything.
Definitely. So Dr. Santosh, actually, interventionologist, hepatocellular carcinoma is one malignancy where interventionology is not just a supportive department, it's in the forefront, right? So in this case, it's a very early HCC, stage BCLC0. So how do you proceed in this case? Means if you are asked in MDT, what is the treatment modality which you will proceed with for this?
So a very early stage lesion, stage 0, ablation holds a very important role because it's equivalent to surgery and mainly transplantation and resection. So ablation should be definitely considered in this patient, and I would be concerned about the ascites around the liver for choosing the modality.
Yes.
And also we don't, for the second question, we may not require any biopsy because it's an LR5 lesion.
Yeah.
And we generally don't biopsy an LR5 lesion.
So again, a second question, it was not scripted, the unscripted question. What is the scenario in which you ask for a second imaging, and in which scenario you ask for a biopsy in these patients?
So whenever the first imaging modality is, it's not conclusive. So we do not have a conclusive evidence that this is definitely HCC. That means it's not LR5, and the patient has suggestive symptoms of AFP positivity or PIVCA positivity. Then we should go for a second imaging.
Okay, sure. So regarding the biopsy?
Biopsy LR5 we do not proceed according to the current guidelines. LR4 we may have to discuss in an MDT and decide.
Yes.
If biopsy is not with, then we will generally request for an early follow-up imaging.
Yes. So as Dr. Santosh said, actually biopsy till the last guidance if you go through, it was just probably reserved as problem-solving modality, means MRI is inconclusive, you go for CT is conclusive, you go for biopsy if clinical suspicion is high. But now what the ACLD guideline is also saying is that yes, for research purpose, we need more and more biopsies because immunotherapy is coming ahead, we need more and more biological markers for that. So outside of trial also, biopsy is being encouraged by ASLE guidelines. Yes. So these are the lyrides by which we diagnose HCC. Just Dr. Santosh, can you just shed some light? Means more than 2 cm lesions, artificial enhancement, single major factor. It is LR5. But there is some doubt, not doubt, in between 10 to 90 millimeter lesions, if it is artificial phase hyper-enhancing, what is the criteria to call it as LR5?
So we generally look at if we have 2 scans, interval growth is given more weightage. So that will go for LR5. And if one modality is not conclusive, we can go for a second modality.
Yes,
so
exactly.
That
Means for 10 to 90 millimeter lesions, if it is only means capsule enhancement or capsule-like enhancement is LR4. But if there is washout or interval growth, it is LR5 and you can go for treatment of these cases. Dr. Vignesh, we are into the era of liquid biopsies more and more, right?
Yeah.
So, yes.
As of now in HCC, it is not yet well established. So we are not routinely doing it.
Yes.
And immunotherapy and chemotherapy as a neoadjuvant setting in this too small lesion is far-fetched.
Yes.
I would rather consider surgical aspect.
Yeah. So let's hear what the surgeon has to say regarding a deep-seated lesion, 1.3 centimeter Lyraid's 5 lesion. How will sir proceed?
Yeah, typically this patient was decompensated. Even a small lesion transplant would be the first option.
Yes.
But in case it looks like it's a well compensated cirrhotic, although the liver appears pretty shrunken.
Yes.
It's not, the size and the morphology of liver is not very well correlating with the, the lab values given.
Yeah.
So theoretically, if you see this, it may be, somebody may think that this patient may be a good candidate for liver resection. Although less than 3 centimeter tumors, although it's said that ablation has got equal results as liver resection. If we see carefully, the long-term recurrence rates are much lesser if the patient can be resected.
Yeah.
So this particular patient, I'll be a little worried about resecting, although on paper looks like this a patient can be a resection patient because the liver is pretty shrunken. Was there ascites also?
There is a subhepatic fluid was there, but there was a recent history of SBP and 2 weeks follow-up. Ascites are resolved. Yes.
Okay, so SB, so this is a decompensated cirrhosis.
Yes.
So no resection. Patient is a candidate for transplant. You can do a bridging ablation as a bridge for transplant.
Yes.
If the transplant is going to be delayed, bridge. If the transplant can be done within a month or so, directly go for transplant.
Definitely. So as sir said, the patient had financial issues. Patient was not a transplant candidate due to purely financial issues. And in this case, the patient went for ablation. You can see some ascites there during treatment, but this was mainly, this case was probably almost 5-6 years back, but the patient did well actually. For 2 years follow, we had the patient. And after that, as I said, the liver was already atrophic, patient decompensated. And in spite of repeatedly that transplant is the only option for you, patient succumb to the disease. So, we say that CC, we have data now. Actually, there's very strong data by the Hong Kong trial, SURF trial. There's very strong data. Up to 10 years data means the SURF trial and the Hong Kong trial actually has 10 years follow-up. That is the disease-free survival and the overall survival is similar in surgical resection and ablation. So, again, a question for you. How do you follow these patients? Means we know that HCC is a pre-cancerous condition. It's not the end of the story after you treat them. So how do you follow up these patients, and is it a lifelong follow-up, or you just stop follow-up after some time?
So a cirrhotic liver is like a soil which has got weeds. The weeds just it's going to keep coming. So depending upon the etiology, the annual risk varies from 5 to 10%. So generally the guidelines all say that it has to be lifelong follow-up. 6-monthly ultrasound and FP are the ones which is supposedly cost effective. But I think that it's going to be tailored to individual needs rather than that.
Yes, exactly. So in our practice, actually, how we do is after any ablation treatment, after 1 month we do imaging. First year, 3 monthly. After 1 year, there is no recurrence, 6 monthly. And CT or MRI totally depends on what modality was used as a first treatment. So going to case 2, 60-year-old male patient, RIS 5 lesion segment 2, child B7, AFP 35, we've got to 40, HSCG positive. You can see the lesion here, right to the extreme. And this is intraoperative imaging. Don't go with the intra-ablation imaging. Don't go with the ascites. It is an artificial ascites that was created to increase the visibility of the lesion. So Dr. Santosh, since the guidelines, even the BCLC latest guidelines say that for very early HCCs less than 2 centimeters, ablation is the way forward. How do you proceed with this case? Is it so simple to decide that all very early HCCs go for ablation?
Yeah, sorry. So it's not like a mathematical formula. We have to tailor the treatment to the patient. So if we see this case, this lesion is in the left lobe in the extreme segment 2 or segment 3, and it's subdiaphragmatic and also close to the stomach. So this lesion definitely poses the risk during ablation of diaphragmatic injury as well as injury to the stomach. So we have to have special precautions to avoid it. So what generally we do is we do a hydrodissection to separate, as we have already done, it's an artificial ascites, to separate the diaphragm as well as the stomach from the lesion.
Yeah. So actually, Dr. Pari, the case comes to MDD, child B7, very extreme lesion that's partially esophageal. What will be your first modality?
Yeah.
Person is not a transplant candidate. He's 66. Yes.
Yeah, he is well compensated cirrhotic, and the location of tumor is in one corner of the left lateral segment. And if you see the anatomy of the left lateral segment, it's like tongue-like. It's basically it's summonable for a safe laparoscopic resection.
Yes.
So this patient can be considered for a lap segment 2 or 3 resection very safely.
Yes, sir. Exactly. So the treatment, actually the patient was sent to the surgeons for evaluation, and due to high anesthesia risk, they said that it's not possible, and purely due to anesthesia risk, surgery was not done. Otherwise, surgery was the preferred treatment modality for this case. And in this case, actually, to the radiation oncologist, Dr. Anand, is there any other option? Means SBRT, means in this location, is it possible?
Okay. So definitely it's possible. So the question here is how much control can we give in this location? That's the question. So SBRT is possible everywhere. So since the two curative options are out, okay. So the one limitation here will be it's quite close to the stomach. So maybe we will have to compromise a bit on the dose. But if you see the latest, I mean, our radiotherapy in HCC is a very recent, modality that has come in. So we are still evolving. The exact dose is not yet defined. So usually a dose is compromised in this location. So if there are no other option, yes, the SBRT is definitely an option in this location itself.
So yes, unfortunately, there was an option available, and ablations. Yes, this is another question for you. Actually, we hear a lot of SBRT, EBRT. Actually, there are a lot of radiologists here who don't know the difference between SBRT and EBRT and proton beam. Actually, there is an image for you. Can you just briefly describe how these differ from each other?
Okay, the rightmost panel is a conventional RT, which is almost out now. Nobody does conventional RT in liver anymore. So EBRT is an external RT. All the three of them are EBRTs, external RTs, and these are different ways of delivering RT. The rightmost was given, it's no longer given. SBRT is currently what is being pursued in almost all the centers except for a couple of 2 centers in India which have got the proton therapy. So proton is a different physical property. It's a proton, it's a hydrogen nucleus. So it has a different physical property of energy deposition and delivery. So that gives better conformity. If you can see the low dose bath, the blue wash. So that's very focused. So that's a proton. But SBRT is, as far as the high dose is concerned, if you see the red and the orange line, it's equally conformal. So it's a way of delivery.
Yeah.
So do you want me to go more technical? No.
Thank you so much. Actually, we have a lot of time. We are the last people on stage, so we can go as long as you want.
Is there one-on-one comparison between SBRT and proton therapy for such HCCs?
So these have been dosimetric trials. How the doses developed, it's almost equal to a phase 1 or a phase 2 trial in a drug trial. So we have that, but we don't have a randomized comparison of a proton and an SBRT. But see, it's basically an availability of a technique. So I have a proton, I would prefer a proton because we know that it's going to give a better dose conformity. And there is no equipoise here because no radiation oncologist will probably not dare to do a head-on-head randomized trial because there is no equipoise in our mind. So it's the availability of the technique rather than...
Yeah, actually, from whatever panels we have been part of, people who have proton beam therapy swear by it because the toxicity to liver is much, much less compared to SBRT.
So when we know that your rest of the liver is not going to get that low dose bath, it's very difficult for us to randomize a patient into
Yes. So this case actually, one other modality that we have not discussed till now was employed because ablation in this case we deemed as risky in the sense that it was very close to stomach, it was not getting separated. In this case, what we did is put a 20 gauge needle into the lesion and just did alcohol ablation. And we all know that ASLD, BCLC guidelines, everybody, but it says that the results of lesion for less than 2 centimeters is compared with the ablation. So in this case, PA was done with very good results, long-term follow-ups are there. So Dr. Vignesh, again, a question for you, means you're a person who has not had a role in any of the cases till now. Is there any case means role for you in this case?
Adjuvant interferon has been tried, but then had more side effects than benefits. So as of now, interferon is not being done on a routine basis.
Yes.
Atezolizumab and bev immunotherapy is under consideration, but then not yet well established.
Yeah, so still no role for you in this case. So next going to case 3, probably you'll have a role in this case. 64-year-old male patient, 1.5 cm Lari's 5 lesion, very hilar location. Child A, AP6, PUCA2 78. Santosh, Dr. Santosh, again starting with you because you claim that BCLC 0 is your domain. So how do you go about this?
So another high risk feature here is a central location close to the biliary and portal venous structures, hepatic artery. So we need to be concerned about injury to the bile duct. We need to be aware that heat sink effect plays a key role here. So we have to choose a modality wisely. And of course, if there is any modality that can avoid these risks, then I would prefer that.
Yes. So in this case, very high profile patient was a serial follow-up. We started following this lesion when it was 1 cm in size, became almost 1.5 cm, 1.6 centimeters as we discussed. AF was stable, but there was definitely interval increase in size. Washout was the Lari's 5 lesions. So, Dr. Pari, what are the curative options at CC? In this case, 1.6 cm CCs, will you consider transplant?
Yeah.
And age, I'll just tell you, is a 64-year-old male.
Yeah, 64 is okay.
Yes.
The most important consideration in my mind is location. It's pretty close to the main pedicle.
Yes, sir.
We don't know, after 3 months if we're waiting on it, you may find that the tumor had already gone into the portal veins by the time you do the next imaging.
Yeah.
So that's a big concern. And it being close to the main portal pedicle, we can't really get away with a small resection. You may end up doing a major, right appendectomy, right posterior segmentectomy, which may not be treated well in cirrhotic patients. So, despite the lesion being just a small one, 1 or 2 centimeters, the location makes it a candidate for a transplantation. I will really counsel them for transplant because such lesions, the next time we had so many patients who come up with portal vein invasion and then the transplant option is out.
Definitely.
So that's a consideration there.
Yes. So the patient was sent for transplant and as a bridge to transplant, yes, IRE, Dr. Santosh has already answered this. Options of IRE serial electroporation is a non-thermal based ablation technique. And second technique that we gave the option was SBRT. IRE unfortunately is like a proton beam therapy, only 2 centers in India have that, Medanta and PGH Chandigarh. So we didn't have the option of that. And we sent this case to the SBRT person and Dr. Vignesh, you are up. So how do you...
I would answer that.
Sorry, yes.
So this would be a very good case because it's bridging.
Yes.
The liver functions are good.
Yes.
The location is not a problem for us, and because it's a bridging, we don't need to deliver such a high dose.
Yes.
So that's a very good opportunity to give a local therapy and bridge for the transplant.
Yes.
So yeah, dose modification for the hilar region. So there are reports, but see, unless the deodorant, in our teaching it said that unlike any other site in radiation oncology, the liver is our major problem in the liver irradiation. So if the liver functions are good, we are good. And second is duodenum. I think duodenum is well away from that.
Yes.
And third would be the central, the biliary structures, which can be given. It's not a very, it's a very small tumor. It's not hugging the biliary structure, so it's very easily doable.
Yes. So this is one of the most important lessons or takeaways that give to all our endometriology colleagues that never ablate a hilar location lesion, you will end up causing a major biliary stricture or a bile leak, and that will deem the entire that lobe atrophic within just a few months' time. Even SBRT or tear have been attempted that can be done there, but even for them, actually, dose models are required because even they can cause biliary injury. So in these areas, if you have, IR is the best modality, but if you don't have, SBRT is a very, very good modality we have in your armamentarium. So SBRT was done with good results. This is a 3-month follow-up. And Dr. Anand, yes. Actually, post SBRT, do you have instances where the report says that there is a viable tumor remaining, and the patient comes back to you very concerned that the treatment did not work? So how do you deal with that? Means 3-month follow-up, the lesion remains same in size.
So it's an enhancement, you mean?
There is an enhancement.
Yeah.
So, there is no increased enhancement, there is no increased diffusion recession.
So this is how the responses happen. So initially the enhancements enhancements persist after radiation. It takes a very long time, maybe around 6 months to the enhancement to go down.
Yes. Actually, the response assessment after radiation-based treatments is completely different. It's not again, what do you call that? It's not
tumor.
It's completely different. It's not M-RECIST criteria. There's a different criteria for radiation-based treatments, whether it's SBRT or tear. If the lesion remains same size without any increase in enhancement or increase in diffusion restriction, you don't call it as a viable lesion, you call it as a known lesion. So you don't need to go and treat that. So Dr. Pari, actually, this case underwent SBRT as bridge treatment. And after bridge treatment, is there a time period you want to wait to see the response to treatment, or you just go and the next month or when the finances are ready?
So by bridge treatment, what we mean is the patient is within UCSF or Milan's criteria, he is good to go. So the moment his finances or logistics are ready, the patient is good to go for transplant.
And downstaging?
Downstage is different.
Yes.
So if that's called downstaging, it won't be called as bridge then. So if it's a downstaging treatment, we downstage patient or some centers.
Yes.
And then wait at that point for at least 6 months to see whether the patient has a prolonged or a persistent response in the downstaged state. So this patient is as such a good candidate for transplant right away. So once the finances or whatever the logistics are ready, he is good to go.
Yes. So there's another important terminology that you guys have to know. One is bridge, one is downstaging. Bridge is just treating the lesion there is. This patient is already a transplant candidate. As soon as the patient transplant, do the transplant. Downstaging is different. Downstaging, you decrease the size of the lesions to within the transplant criteria, and then you have to wait for 6 months at least to know that it's a stable response. So this was a retrospective study, 151 patients across 5 centers across the world that compared the curative potential of ablation therapies versus surgical resection and liver transplantation. Found is that from 2014, the response rates for ablation therapies have increased drastically, so that it's comparable to surgical resection. However, they still dwarf the cure rate of liver transplantation. And there is something as years of life lost. For patients who are less than 60 years of age, just look at the years of life lost if they go for ablation, at least 20 years. So patients who are less than 60 years, even if it's early HCC, it's transplant as the first option. Bridging is different matter. But this another problem that it's not a practical solution. You have a shortage of those things. So many of these patients are going for local regional treatments. But curative treatment, there is nothing beats liver transplantation. Thus our curative rate of liver transplantation is 70 years. For surgical resection ablation is around 20 to 23 years. Next case for a 60-year-old male patient, child A, 2 cm Larites 5 lesions, AFP is 256, PIVCA 2 is 50. This is a lesion. Dr. Arul, what is the role of tumor markers in HCC? Why do we see so many means? This is the only HCC in this case series that are AFP. Why is that?
So tumor markers are helpful both for screening and the surveillance and to see that how things are. So we burnt fingers. Initially, we used to transplant any amount of AFP, and then the criteria started to come down. So AFP more than 400 became a strong absolute contraindication for transplant. Now it's cut to 100, so people don't take them for transplant. It just tells about the biological nature of the tumor. But there are some sort of problems with AFP as such. It's not specific as such per se. So let's say, for example, if the patient's got active viral replication, which you used to see with hepatitis B and hepatitis C, AFP used to be raised. So that's the problem with that. But definitely in a patient who's been stable with no active viral replication, tumor markers certainly have got a role. There have been several tumor markers and biomarkers and have all been tried, but we've not been able to find out a perfect answer. So still AFP remains the best one. So Gallet score, HS score, and all sorts of things have come up in all those things, but AFP remains the best to date.
Thank you, sir. So actually, this is just to remind you that only around 50-60% of tumor HCCs secrete AFP. So we see a lot of reports of CT or MRI. In the final report is called biopsy or AFP. It's not like that. AFP has no role in diagnosis of HCC. Please, sure. You can enter any time.
Okay, two scenarios. Let me describe. One, treatment naive patient on follow-up, non-A, non-B, NASH cirrhosis on follow-up, slowly creeping AFP, undergoes a routine triphasic CT negative. 3 months later, undergoes another CT negative. 2 months later, one more MRI negative. All modalities are negative. This is scenario number one, and we plan to do what's next. Number one. Yes. Number two, patient undergoes microwave ablation. A significant drop in AFP and PIVCA. 3 months follow-up, good. 6 months follow-up, good. 1 year follow-up, creeping AFP and PIVCA. No lesion on follow-up CT and MRI. So is the situation familiar to any of you?
Yes,
it is.
So yeah,
yes.
please.
So I'll just answer that question. We have a team panelist. Please, sir. Dr. Pari, sir, please.
Sure. First question, creeping AFP in a cirrhotic liver, very, very suspicious. I would believe that it's still there, just that we are not able to find out. So I assume that you have done a good contrast MRI. Yes. We would probably, keep doing MRI till we find out, because I'm assuming that the testers and everything, other sources of AFP have been seen and ruled out. So it's there. You're not able to find out. It's going to show up sometime in future. I would keep the frequency of MRI probably lower, maybe once in 2 or 3 months.
So I just add to that.
One of the scenarios we've been caught out is an early infiltrative HCC. We've been caught out. That's been the characteristic that what we find out that it's just a parenchyma looks okay with sort of several modalities of imaging. Follow-up imaging, 3 to 6 months later, we've just been caught out that it's an infiltrative HCC, which we missed out. Yes. So that's what the typical scenario in these sort of situations, yes. What we see.
Actually, this is... And I assume that you also ruled out, chronic active hepatitis and all those things which can also lead to AFP rise. So if there is activity in the liver, it can give rise to AFP elevation. I'm assuming that those things have been ruled out.
So this one scenario actually does not address in BCLC or ACLD guidelines last time, but this time ACLD guidelines do say that in case the tumor markers are high and the CT is negative, you go for MRI. But even if that is negative, that is the role of PET scan in diagnosis of HCCs. So you have to go for a PET scan. If PET scan is negative, again follow with, maybe you have 5 minutes, please? Yes. So if again PET scan is negative, you go for serial imaging 3 months, 3 monthly. And if 2 positive images are negative, then they go back into pool. And regarding the other one, as I said, after treatment, pre-treatment if AFP goes high, post-treatment nothing is there, everything back came normal. Again, this creeping is you're just missing, it is there, you just have to keep on imaging until you find it. Yes.
Thank you.
Yes.
We don't.
Dr. Vignesh, this case.
Nowadays we don't call chemo or we call it systemic therapy.
Systemic therapy, sorry.
Systemic therapy is considered whenever we call it a non-metastatic, inoperable, and when we consider it for a palliative thing, then we go for palliative systemic therapy. As far as chemotherapy is concerned, it acts on fastly multiplying cancer cells in various phases of cell cycle, inducing DNA damage and cell death. Whereas immunotherapy, if you look at, there are immune surveillance mechanisms is escaped by these cancer cells. So by blocking these receptors, these T cells are able to effectively eliminate the cancer cells. That is the basis for immunotherapy.
Okay. So in this case, actually, hepatocellular carcinoma, in this case, AFP is and high AFP directly correlates with high chance of recurrence. In this case, what is the first modality? You go for immunotherapy or you go for chemotherapy in this case?
See, once we call it as it is for a patch setting, we go with immunotherapy plus along with ADI plus BEV is the best option available now. Adisozumab plus bevacizumab, which is a VEGF inhibitor with an immunotherapy. But in case they are not for it, then we go for lenvatinib.
So actually, sir, you said that AFP more than 400 is a contraindication for liver transplant. Dr. Pai, is that 400 or is it 1000 for you?
See, most of the countries have put the threshold as 1000.
Yeah.
I guess where a couple of countries had 400 as the mark, the cutoff point, but most of them it's 1000.
1000. Yes. So Dr. Santosh, actually, in this case, we'll just finish with this case scenario. Hardly 2 slides are left. Dr. Santosh, in this case scenario, patient is 2 centimeter, very early SCC stage 0, BCC 0. Is there any protocol change for ablation in your practice if you go for ablating these cases, these lesions?
So it's a subcapsular lesion, slightly exophytic, but not close to any organ. So upfront ablation is good enough, but considering the high AFP and PIVCA, it's always better to have a regional treatment as well, because it's going to have definitely a microvascular invasion considering the very high AFP.
Yes.
So that's where the combination treatment works.
So that's where combination treatments, where you combine TACE
Can I
plus
just,
ablation. Please, sir.
Can you combine ablation with TACE or TACE in such cases where
Exactly. In this case,
high AFP, slightly bigger tumor?
Yes.
How about combining ablation with TACE?
TACE, yes.
There is definitely a role. That's what I think Dr. Rajesh is about to say.
So for the last 5 years, if you ask me, any lesion that is more than 3 centimeters in size up to 5 centimeters, AFP is more than 100, PIVCA is more than 100, or the C is showing, C2MR is showing high, means HCC is not a single lesion, means single type. There are 5 morphological types of HCC, at least 5 histopathological morphologies of HCCs. First 2 means perinodal infiltrate type, multinodal infiltrate type, or the infiltrate type. They are the aggressive type HCCs. For those in our practice, for the last 5 years, it has been combination treatments if they are ablation candidates. And in this case, TACE plus ablation was combined, and there is different data that says that combination treatment is much better than ablation alone for HCCs that are more than 2 centimeters in size up to 5 centimeters. So, Dr. Santosh, is for small HCCs, is TARE an option?
See, yes, the legacy trial, which has actually changed the practice and got TARE into the FDA guidelines for smaller lesions, solitary lesions. So definitely shows that the curative response rate is definitely better with TARE compared to other local regional therapies, even comparable to ablation.
Yes.
So that's where TARE is also an option if the patient receives a segmentectomy dosage.
Yes. So to our audience, actually, can you just briefly tell what is the mechanism of TARE?
Yeah, it's a selective internal radiation therapy. We inject particles. They are either resin spheres or glass spheres, which emit beta radiation. And beta, as you know, has a very short penetration. And actually, these particles are around 20 to 40 microns. They get deposited in the precapillary arteriolar bed. And they do not have much of an embolic effect, but they actually emit radiation and lead on to tumor death.
Yes.
So this is a mechanism of TARE.
Yes.
And the advantage over TACE is the absence of embolic effect, so the tolerance is much better. And of course, we can modify the dosimetry to achieve a very good tumoricidal effect compared to TACE. And the various trials that are being conducted have shown in the recent past that TAR is definitely has definitely an edge compared to the chemoembolization that we've been doing.
Exactly. So actually, the gold standard for ablation treatments, local regional treatments, is complete pathological necrosis, and there is data that says that the complete pathological necrosis rate is highest for TAR, but not conventional TAR by radiation segmentectomy method. So just one slide. This is the last slide actually. Any local regional treatment that you're planning to do has to aim for complete treatment, complete response, and not leave behind any lesion, because there is a long-term data means from last 20-25 years, there is data that says that if the lesion is only partially treated, the chance of recurrence of such a patient being transplanted is much, much higher than a lesion that had been completely treated. So in conclusion, MDT is the way for HCC treatment. This is one of the slides, one of the cartoons that we made for last ISVR, our national conference. All the modalities are very important. It works in tandem. The conclusion is that liver transplant has the best cure rate of 70%. Surgical resection has a cure rate of around 70%, 26%. Ablation was 18% earlier, but from 2014 onwards, the cure rate is 26%. And the potential new intents as curative treatments are radiation segmentectomy, combined treatment, and SBRT. Thank you so much for your time. Thank you, dear panelists.
We thank our esteemed group of panelists and speakers for that enlightful discussion.